lot of people want to vacation in summer.
Okay. Everybody likes last summer, right?
There will be a few days in summer everybody wants.
Yeah.
Yes, that's another
Like, the census.
Hey, Geneva, it's Scott Cates. Can you hear me?
I know when you talk about numbers like this, it's I would say it's less probably, but it's patient are very.
Hey, Geneva, can you hear me?
You can draw a patient from places where you just sit in this chair.
Exactly.
And the patient will be taken care of. Some places you don't have to be the hospital. Patients will be taken care of. That's the kind of fact. The academic should be working with that. Right. No matter have this have that thing. 8 if they do night, they see 4 there.
Yeah.
4 cat. Yeah. No. When I did night, I was in the hospital stuff there. I used to come upstairs and stand under 14 downstairs.
That was
2000. Oh, yeah.
Oh,
2014. Like I used to have that 26 night with all the cross cosine, bunch of notes down there and cosine. Yeah, so but now it's changed. You don't have cross code after 11 o'clock. So that takes a week. And now we have 2 nurse practitioners. That is 1 nurse practitioner. So we changed it also. We have been very sensitive about the night. The day guys, it's still there's a lot of manpower and bodies you can.
Yeah, you can just look.
Yeah. So the catch is not your case. We want that, and you say, well, I just want to do night because I don't want to be with the drama and the concerts and stuff. So especially the concerts. Make further. But of course, if you want heart failure experience, I did it available. And just tell it. So if you ask me, as I said, Henry Ford Maine, the water. This is, and if somebody does mechanical career hospitals, Henry Ford Maine, it depends. You need some teaching time, H5 and I1 you don't enjoy because of the culture. West Bloomfield is fine. You don't have a chief counselor, find out this in a different league. They specifically can say that we are not going to use this place until we die. I guess even if you have dementia, you can still do it. Just as long as you put in a console, things will get done. Things happen. Things happen. That's the system. When I go and work there, I had a patient with common bile stone and jaundice. I put in a GI console. I went for lunch, came back, patient was already taken. Here they will ask hundreds of questions. Why this? Why this? When did the patient has asked me? Why? Halo 1, Halo up. Nobody will ask you. Thank you. Yeah, guys, try. What do you do? Yeah. Here, that's a couple of them are like the one in the last. Here, we have this need to call the resident, they give it up. Okay, we will come, we sit down, talk to you, put down the orders. There are a lot of private positions.
Yes.
A lot of you cannot mess around with private. They will take their business. Hospital is very protective of private. We don't have private.
Dr. Katz?
All the council, all the private. Right?
Dr. Katz, can you hear me?
Anytime of fellow use of time, call. Even if you don't know how to manage CHF, but I can help you. Because they are private. Like we are not.
Yeah.
Here to deal with. When you become a fellow, we will deal with you. We have no option.
I know. Yeah.
And you will, why do you want to need or need this?
Yeah.
Why do you need this console? Remove this console.
No, I kind of like, I know this, everybody thinks this about like the environment, that how.
Then when people come to medicine council, I tell them, don't give pushback. We will just go see the council. If there's nothing, we will sign it. So for 1 year, this is, I mean, you don't have to go anywhere, you're local, this is fine.
Yeah.
It's a career hospitalist position.
That's good.
And the other kind of people who come here is whose wife is doing some fellowship, they want to come here, they need, especially Indians, if they need visa, there's no other place around the sponsors visa.
Oh,
So that's the cap. Like I came here for like my wife, 2 or 3 others who came here because their wives are residents of Lagos here. There are a bunch of them previously came because their spouse was here. So that's the other kind of group who come. We want to make it long term kind of, but still sometimes Dr. Way of do the pride out and get people who want to do couple of years. This means there will be a lot of turnover.
is there any like vision about changing or?
No, sometimes you feel that's the right thing for this model for this place.
Yeah.
You cannot change the hospital.
Yes, exactly.
Can we go and tell each and every surgeon or department or including Dr.
No.
Sher and GI and cardiology change their we
He's
cannot-
the only
it's a
one
culture.
that, he's the only one that know how to deal with them. Because, I mean, he's the one that hired everyone.
Yeah, I mean,
He just made, but that doesn't work. I mean, it's not like.
yeah, so you cannot, it's not, we can't do it, it's a culture, we have to, where there is resistance.
Well, like the same fellows, if you being hate.
Dr. Katz, can you hear me? Dr. Katz?
There's no sugar. Like the hospital. And it's
That was a big.
right, right.
I like 5 or a few hours.
I was until like 2020, I was always planning to make my house one and decide to, but my wife she was private practice. She was on university. He was happy.
Hey, Sarah.
Hi, Scott. How are you?
Hey, Sarah, can you hear me?
Yes, I can.
I'm not sure I understand.
Dr.
Ashley.
Katz, can you hear me? I made you the co-host, so you can share your screen whenever you're ready.
So it says host disabled participant screen sharing when I tried to click on share screen.
Let me make you a co-host as well, Dr. Though.
Okay. Yeah,
There you
if
go.
you can have all the speakers
Yeah, I'm just waiting on the others to join the meeting.
to join.
I've
Okay.
added Dr. Katz and yourself, and I'm just waiting on the other people as well.
Cool. Thank you.
Do you know if the share screening, the screen share is working now?
Here,
Dr.
I'm going to
Though?
try it now.
Awesome.
Just a sec. You can see my screen?
Yep, I can see it. Definitely. Yep.
Are you? Okay, so I heard it. Hurry up, get Sarah. Just sign. Yep. Okay. I didn't even fill them out yet because I heard I have to hurry. Sign down there. This is all Jackie Cannett's assistants. Thank you. Thank you.
Thank you.
Okay. Oh, your door closed now?
Yeah, thanks.
Okay.
Danielle,
Yes, Dr. Gov.
would you mind sharing the Zoom link with Reem?
Oh, for sure. Let me email her this.
Thank you.
It is also embedded in your flyer, but I'll send her the.
I don't think I sent that to everyone.
No problem. I'll do it right now.
Thank you. I think in the interest of time and knowing that we have a lot of ground to cover in a short period of time today, we should probably get started. So I want to thank everybody for joining us today. We were asked to put together a kind of mini PERT Symposium for our division, reviewing kind of the latest updates and guidelines and best practices when it comes to management of patients with high risk submassive PE and massive PE. And so we are approaching this in a very multidisciplinary way, not unlike how our PERT team here functions. And so I'd like to first welcome Dr. Cates, who has been a member of our team since really the very beginning and is our in-house anticoagulation expert guru, and is going to be talking to us today about approach to risk stratification in patients with acute PE. And with that, I'll turn it over to Scott.
Hey, thanks so much, Sarah. Let me get this screen shared. Give me just a second. Sarah, just checking to make sure you can see this.
Yes, we can.
Great. Okay. Well, thanks, everybody. So I'm going to give a talk exactly on what Sarah, exactly opposite to what Sarah asked me to talk about. So I'm not going to spend a lot of time actually on the high risk or intermediate high risk PEs, where all of the PERT action is. I'm going to bring you a hospitalist perspective a little bit also, and just a little bit of insights on the other end of the spectrum on those patients that we can maybe discharge earlier. But I am going to keep this focused on the risk stratification tools that we have. I think it's important to remember that probably a quarter to a third of the patients that present to the emergency room here at Henry Ford could probably be discharged from the emergency room, although we clearly don't do that here at this time. Here's my potential conflicts of interest, and Sarah will have these slides to share also. I basically have done consulting with two of the major DOAC manufacturers, which is probably most germane to this talk. So, well, so here's a case just to get us started. A 62-year-old comes in with an acute PE. They don't have cancer. They don't have heart or lung disease. Their oxygen saturation is 92%. Systolic blood pressure is reasonable. The pulse is 116. The right ventricle to left ventricle ratio is less than 1 on the CAT scan, and the troponin is normal. And the question is how would you classify this patient? And what I've really done here, and because I think most of us know this, but I think at least for our house staff, maybe on the floor, maybe not so much for the fellows, we probably should get used to this. And what I have highlighted in blue are the numbers. And the way I remember the Simplified Pulmonary Embolism Severity Index, or the SPECI score, is 80, 90, 100, 110. Because I think that's easy to remember. And then I think you can also sort of figure out what the age and which vitals go with what, if you think about a pulmonary embolism here. And then, of course, also what puts a patient at risk is if they have cancer or if they have heart or lung disease. So this is, so the European Society guidelines, which is really what everybody speaks to. Certainly it dominated our conversation at the October PERT Consortium national meeting, is that this is the color coding that maybe many of you have seen. High risk is the patient's in shock. So I think that that's sort of straightforward, and we scramble. We're going to have lots of talks on sort of maybe the best way, or more importantly, the options that we have to address that. It's intermediate high in the darker yellow, which is saying that your PESI score, or simplified PESI score that I just alluded to, is certainly not low risk, and that you have both RV dysfunction, whether that's a right to left ratio of greater than 1 on a CAT scan, or you see right ventricular strain on echocardiogram, and you have a positive biomarkers. In the prior, I think 2014 guidelines, they included both BNP and troponin. In this updated guideline, they are really only including troponin now. And then if one or the other of those is positive in the intermediate, we call that intermediate low. Now, there are lots of variations and you have to use your clinical wisdom along with this. But I think for probably folks that are early in their career, i.e. our house staff, this is probably a wonderful structure for them to at least start to frame the risk of the patient. What I have circled down in the low risk category, which would be a simplified PESI or the longer PESI score as being normal, is that an assessment is option to look at the right ventricle and or troponin. And I think we have literature that shows that a modest number of patients will score low on the rubric, but will be have one of these positive. And then of course that changes our mind. I tell you frankly, in my experience, it's hard pressed to get a patient see a patient in our emergency room that hasn't had a troponin done. And of course, you always have at least a ratio on CAT scan, or virtually always, with a pulmonary embolism. There are the guidelines that I just showed from Europe now 2.5 years ago will recommend either the pulmonary embolism severity index, which is over on the left, okay, or they will recommend the SPESI that I have described to you. Both have been quite well externally validated, and both do a pretty good job of sorting out 30-day mortality. I think this is the key part with this measure, is it is a mortality predictor. Okay, so that's how I use this, because frankly, that's what I'm most scared about, is death from PE. That's what I'm most scared about if I'm sending a patient home early on day 1 of hospitalization, or if I'm recommending that from the emergency room. So this is where I've always grounded myself. So there is also the Hestia criteria. There's developed out of a Dutch group now about 8 to 10 years ago, I guess 11 years ago now with this reference. You can see what's listed here. But this was not designed to be a mortality predictor. And that's stated quite clearly in the guidelines. This was more can the patient practically go home if they're low risk? And you're going to see things on here like, do they have severe pain needing intravenous medications? So for all of our patients that are having a dilaudid deficiency, I think maybe you can't send them home. If they need oxygen, obviously we're not going to send them home. If there's medical social reasons, this was developed by a Dutch group. Of course, we have the whole copay issue here in the US. So I see this more as a pragmatic checklist on when we can discharge the patient. I see this as a mortality predictor. So I think they go hand in hand, but I always do a PESI score, actually the simplified PESI score, because I can memorize it when I am evaluating every single patient, because I want to get an idea of what risk of death in the next month is. Okay, so that is called a clinical prediction rule. There are lots of clinical prediction rules. They're in various amounts of development. How good and how strong that evidence is on whether we can use that. This is an evidence pyramid, down from when they're first developed at a single institution, which is sort of the baseline in the first studies. As we move up to the top of the pyramid, what you really would like to do is you'd actually like to see a study that use this for patient management, so we know if it does what it's subscribed to do. Zach Dimitris, one of our chiefs, and I are working on another project, and I borrowed this slide from him. He built this one. So we now, just of last August, have the first study to look at that. And this is a question is, does an upfront PE prognostic and management pathway reduce hospital length of stay? This is a randomized trial, 500 patients, 498 were in the analysis at 9 Spanish academic hospitals. The intervention was to use a standardized pathway. I'll show that in a second, compared to usual care. And the primary outcome was length of stay, i.e., if we do that reasonably formulaic, have a process that's organized to do this, can the patient spend less time in the hospital? And then the secondary outcome was 30-day clinical outcomes, including mortality. I will walk you through this pathway that they did. First of all, up in the top left corner, there are no high-risk patients in this because you don't need, frankly, to apply a simplified PESI score to a patient that's in shock. If the simplified PESI score, the SPESI score, was 0, i.e. no cancer, no heart disease, no lung disease, and then the 80, 90, 100, 110 rules that I showed, if those all of those were normal, then the patient was considered low risk. Now, this is a Spanish group of Spanish hospitals. They are still not doing a lot of outpatient discharge. Dr. David Jimenez and I chatted about this paper at the PERT Consortium, and he led this effort. So those patients would be admitted, but they would be immobilized quickly. There's been a long-standing concern that when can I get a patient up with a big DVT or pulmonary embolism, i.e. do we have still clot there that might wiggle and let loose, and do we need some anticoagulation before we do that? I have never understood that thought process, although it is very, very apparent for many folks, and I think that these Spanish hospitals were still living with some of that legacy thought process. But importantly, of all of these non-high risk patients, i.e. normal tensive patients, a quarter of them fell into the low risk category. So there again, I think we have about a quarter of all the patients that come in the hospital probably likely don't need to be in the hospital. And guidelines that I know Sarah's going to talk about, treatment options, will recommend that we treat those patients as outpatients. If the simplified PESI score, you don't have to add the points, it's just if any of those things are positive, then they do troponin testing. Now, I like this for two reasons. One is because I always get a troponin in at least main campus emergency room, so I have it. And certainly it is faster than getting a echo, cheaper and easier. And if the troponin was negative, then they moved this patient into the intermediate low risk category. Remember, I have a little reminder up in the right-hand corner of this. This means that the SPESI score is positive. However, you only have one of the two, RV strain or troponin, as positive. So if it's negative, then it can't be more than one. And so it's intermediate low. And then what they would do is they would mobilize those patients the next morning and then get them set up for discharge. If the troponin was positive, then they did an echocardiogram to see if you get that second component to move from intermediate low to intermediate high, and they would get an echo. There is some literature out there that says that the echo is probably more specific and sensitive than the CAT scan, but at least you almost always have the CAT scan to get you started with this risk stratification. And if there was no RV dysfunction, then you move into the intermediate low. If you have RV dysfunction and a positive troponin, then that is in the intermediate high risk. Only 12% of these 498 patients fell into that. And then they kept those patients a little quiet for 48 hours. We do things differently. I think we move the patients through the hospital faster than this group in Spain, but it can give you at least an idea of how they utilize this risk stratification that we purport in our PERT team also. Bottom line, highlighted in red on the top, is they went from 4 days in the intervention group following a protocol to 6 days in the control group. I think you'd probably shave a day or two off of those days here for most patients in the US, but I think it's still meaningful is that you drop length of stay by a third. And my guess is if we did this in an organized manner, we could probably get similar 1/3 reduction in length of stay. And then here in the middle, highlighted in blue, you just see the readmission rates were similar. Mortality at 30 days was similar. PE related mortality was related. So sort of getting those patients through and out of the hospital faster did not have clinical consequences at 1 month follow-up. So the next issue is I showed you the Hestia score, and lots of people use that, and there are studies that show that you can use Hestia. There are studies to show that if you have a low Hestia score, you actually have low 30-day mortality also, but it was not designed to be a mortality predictor, and lots of the validations for it is not for mortality. So this question does one work better than the other? And these investigators took, again, normal tensive pulmonary embolism patients, and they wanted to know if Hestia was just as good, so non-inferior to the S-PESI for recurrent VTE, major bleeding and mortality, i.e. the clinical outcomes, and superior for identifying a higher rate of patients that could go home. Because if it was as good for clinical outcomes and you could get more patients treated at home, then a bonus. It's a randomized trial, non-inferiority on the per protocol to answer whether the clinical outcomes are similar, and superior in intention to treat analysis for the patients to get them home. Large trial, 1975 patients, 26 hospitals in Europe. The intervention was using Hestia criteria to triage the patients. Comparison was simplified PESI. The primary outcomes I've already alluded to, follow up at 30 days. Here is the graphic abstract that I will walk you through. So from a triage standpoint, if we look at the qualification on the top bar, we see 39% and 48%. So actually more patients qualified for low PESI score than a low Hestia score. So more patients were candidates for going home. But remember, S-PESI is not looking at all the pragmatic issues on whether the patient can go home. And the investigators were allowed to override this. This was a starting point. And when you do the overrides, which is on the right-hand column under S-PESI, the second graphic down, that yellow bar is the proportion that were overridden. So at the end of the day, it was similar to the amount of patients identified to be able to go home. And so I think they complement each other. I don't think it's one or the other. I think S-PESI tells you risk of death. I think Hestia tells you pragmatically, can the patient be discharged early? If we look at the home treatment, how many patients were treated at home, it was nearly identical. And if we look at the outcomes, both overall population, i.e. outcomes that happened in all of the patients, or on the very bottom, the outcomes that just happened in the patients, it was very safe treatment for both. So I think the best thing to do is to use S-PESI to start, and then you can either use, if I can get to the right thing, you can use this list, or you can use other pragmatic lists. I will tell you the thing that is missing on Hestia here in the US is copay for their direct oral anticoagulant or for their low molecular weight heparin as you're over transitioning to warfarin. And Sarah, I purposefully left this short so we could have time for some conversation and made sure we didn't run over, and happy to take questions. Thank you very much.
Excellent. Thank you so much, Scott, for that great talk. We do have about 10 minutes for questions if anyone if anyone has any questions that they wanted to clarify.
This is Dan Moore. Can you hear me?
Yes.
Hey, Dan. Yep.
Scott, if a patient has a low S-PESI and we're on the right-hand side of that page, or sorry, the left-hand side, but they just happen to have a positive troponin that, you know, was done for whatever reason, do you, and the CT, let's say, doesn't show any signs of RV strain, are you doing echoes on these people or just pretending like you didn't see the troponin?
Well, Dan, great question. It probably is really a big issue is, you know, how high is the troponin? Is it a troponin that's positive at 19? Or is it a troponin that some people are causing positive at 5? Because that sort of 4 to 18 is what we're using for not needing to bring the patient into the OBS unit to do a stress test for chest pain risk stratification. So I think it depends on what it is. You know, and you're going to bake in renal failure and all the other troponin stuff. So I think it's still okay to send the patient home. It's not a hard and fast rule, but it makes me pause. It's not a slam dunk. I'm really comfortable. S-PESI normal, troponin was done and is undetectable, and I don't have a big RV on CAT scan. I think that's the ideal patient. The other thing is Dan, pragmatically with the S-PESI, so the age is 80. But now if I got the 79-year-old, you know, and the pulse in the systolic is 1 point off from the criteria, as is the, you know, the blood pressure, and the O2 sat is only 91%, even though they got a negative S-PESI, they still got my attention.
And to add on that point, Dan, the opposite is not necessarily true, meaning if someone has an S-PESI of 0, but they have RV strain on imaging or biomarkers, that will increase their risk profile. So the presence of RV strain will trump the S-PESI, and the ESC guidelines kind of made a footnote of that in their risk stratification scheme to make sure that we weren't just dismissing presence of RV strain due to a low S-PESI.
Yeah. Thanks, Sarah. So that sort of green bar on the bottom of the color-coded chart, you get moved to yellow if you have either of those. And then you get whatever the color is a mix between yellow and green if the troponins are bumped just a tiny bit, as you mentioned. Did that answer, Dan?
Yeah, thanks to both of you guys.
Can I ask a question? This is Jeff Jennings. What about the role in these studies? Nothing came up about getting the BNP to the troponin. Does that add into this risk stratification for the non-shock PE people?
Yeah, great question, Jeff. So in the 2014 ESC guidelines, BNP was in there also. It's my understanding on further studies, it showed that BNP was not that big of an independent risk. And so they dropped it in the 2019 guidelines. I mean, I agree, you know, it's very likely that it's going to get drawn. And if it's up, then, you know, you bake it in a little bit. But I think that when you, my recollection is when you do multivariate analyses with BNP, even though it might be a univariate predictor, it sort of falls out in the multivariable analysis. So they dropped it, or even that, or it's a minuscule increase in the odds of the death. So it really didn't add much. Did that answer?
Yes, perfect. Thank you.
Any other questions? Okay, so I'm going to be talking to you about guidelines, review of the evidence and the guidelines in PE. So I'll just share my screen. You guys can see my screen? Scott, can you see my screen? Yeah, okay. All right, so Management of and really the focus is going to be submassive and massive PE. And so we'll take some time to review a little bit of what the evidence is that backs our most recent guidelines. These are my disclosures. So pulmonary embolism is the third leading cause of cardiovascular death in the US, with an incidence of about 900,000 cases per year. And that results in about 60 to 100,000 deaths annually. And with a very high mortality within the first month of diagnosis. So 10 to 30% of patients will die within that first month. If you look at non-traumatic sudden deaths, PE represent about 10% of that. And looking at our mortality, we've had very little change over the past 2 to 3 decades. As Scott mentioned, we've shifted towards risk stratifying patients with PE into 3 categories: massive, submassive, and non-massive. Non-massive PEs are low-risk PEs and represent the majority of PEs, and having a non-massive PE confers a fairly low mortality of less than 1% in 90 days. On the other end of the spectrum, we have massive PEs, which is associated with very high mortality, around 58% 90-day mortality, but thankfully they represent a minority of PEs, only about 5%. And then we have this large category in the middle of submassive PE that we've come to recognize over the last few decades. These are patients who have PE, they are not in shock, but have evidence of RV strain. And because of the presence of RV strain, they have a 22% 90-day mortality as compared to patients who have non-massive PE and don't have any evidence of that RV strain. Why has there been such little progress? Well, PE has a very variable clinical presentation and is known as the Great Masquerader. It's associated with multiple comorbidities, which often complicate therapy. There's limited clinical trial evidence to guide therapeutic strategies. So recommendations I'll show you for the most part are limited to class 2, typically class 2 for all but the low risk group. And risk stratification classifications haven't been universally accepted by major societies, with variations between the AHA, CHEST, and the ESC guidelines. We also have many emerging therapeutic modalities, which include percutaneous interventions. And so the question becomes, which procedure do you use, if any, in who and when in the patient's time course? The time to mobilize many of the different subspecialties that are needed to take care of these patients to weigh in can often lead to delays in necessary interventions. And so when we think about massive and submassive PE, it's important that we understand kind of how we're defining this. So patients with massive PE have overt right heart failure. These patients are in shock, and shock is defined, and this is an agreed upon definition across the guidelines, as a systolic blood pressure less than 90 or a drop of more than 40 for at least 15 minutes that cannot be attributable to a new onset arrhythmia, hypovolemia, or sepsis. Patients who require inotropic support or those who suffer cardiac arrest obviously are also categorized in that massive category. Persistent bradycardia tends to be an ominous sign and kind of a pre-arrest indicator. And so patients with heart rates less than 40 also fall into this category. In patients with submassive PE, they are typically normotensive with systolics greater than 90. However, they will have evidence of RV dysfunction, whether it's on imaging studies, on echo or CT scan, or biomarkers. So BNP elevation, troponin elevation, there may be EKG changes to suspect or that suggest RV strain. What happens to the RV afterload or in the setting of a PE? So you'll first begin to see RV dilation, which leads to RV wall tension increasing. That results in kind of this activation of a neurohormonal cascade, resulting in myocardial inflammation, increased oxygen demand, RV ischemia and hypoxic injury, resulting in decreased RV contractility. That will ultimately result in decreased RV output, which leads to a decrease in your LV preload. And the way that that'll manifest clinically is a patient's cardiac output will drop and you'll see a drop in systemic blood pressure. All of that will then result in further reduction of coronary perfusion of the RV and RV oxygen delivery or oxygen delivery to the RV, and leads to kind of what we call the death spiral of PE. Looking at massive PE, there really haven't been many studies that focus on just the management of massive PE, but this was a seminal kind of very small series of 8 patients that published in 1995 that looked at 8 patients who presented with massive PE, and they were randomized to either receive streptokinase or heparin alone. The 4 patients who received systemic thrombolytic therapy survived, and the 4 patients who did not died. And it was this trial that really led to a shift in management in patients with massive PE and supported the use of thrombolytic therapy. A meta-analysis was done looking at 5 studies that weren't done in specifically massive PE patients, but they did include patients with massive PE. And the results were pooled to look at differences in recurrent PE or death in patients who received thrombolytic therapy versus those who received heparin alone. And what you'll find is that there was a significant reduction in recurrent PE or death in patients who received with massive PE who received thrombolytic therapy. And that was about evenly weighted between recurrent PE and mortality. However, this came at the expense of major bleeding. You can see there's an odds ratio of 1.98 in the thrombolytic group. Catheter-directed thrombolysis, then kind of the question became, could you administer thrombolytics at a lower dose directly into the blood clot or into the pulmonary circulation in order to hopefully reduce the total lytic dose needed and thus any major bleeding complications and intracranial hemorrhage risk. So the Seattle 2 study, which I won't go through in detail here because I know Dr. Koenig will probably be reviewing it later, was a study looking at 150 patients. It was prospective, single-arm, multi-center, and they did include patients with massive PE, which is important to note that patients were effectively treated for massive PE with catheter-directed therapy. But again, this was a single-arm study that was prospective, but we were able to see that patients did reach their primary output of reduction in their mean RV to LV diameter ratio and reduction in their PA pressures. Important to note, this came with 0 intracranial hemorrhage. And this is why what you'll see practically with our PERT team is that there may be a small subgroup of patients with massive PE who are unstable, but we still think may have enough time to receive catheter-directed thrombolytic therapy, particularly if we're worried about potential increased intracranial hemorrhage risk in that particular patient that would be conferred if we had used systemic thrombolytics. So what do the major guideline societies say? CHEST, they all agree on the use of systemic thrombolytic, peripherally administered systemic thrombolytic therapy in massive PE. More recently, so CHEST updated their guidelines in August of 2021. And you'll see that they specifically commented on catheter-directed thrombolysis. So in patients with acute PE who are treated with a thrombolytic agent, we suggest systemic lytics using a peripheral vein over catheter-directed lytics. And importantly, in patients with acute PE associated with hypotension who have high bleed risk, failed lysis, or shock that is likely to cause death before lytics can take effect, they suggested catheter-assisted thrombus removal over no such intervention. So that's what you hear us talking about, mechanical thrombectomy or FlowTriever. And this is the first time that kind of the CHEST guidelines, which I think are probably the most conservative guidelines out there, gave a nod to percutaneous intervention in this patient population. If we compare what the 2016 anticoagulation forum guidelines were, as well as the 2019 ESC guidelines, they're a bit more liberal, where they suggest both systemic and catheter-directed or pharmacomechanical in appropriately selected patients, which is kind of leaves it a little quite open-ended and broad in terms of who those patients might be. And then the ESC guidelines suggests the same in patients who either have a contraindication to thrombolytics or have received thrombolytics and they have failed. Shifting gears to patients with submassive PE, you'll find that there's clear data that mortality is impacted when there's presence of RV hypokinesis. So this was a study looking at patients with PE and found that mortality rate when RV dysfunction was present was higher at both 2 weeks and 3 months. This has been validated and commonly found in many other studies, where regardless of the modality used to measure RV dysfunction, whether it was echo, spiral CT, or BNP, you'll find that RV dysfunction was associated with higher mortality. And as Dr. Cates spoke about earlier, transthoracic echo tends to help us identify that better than spiral CT. There are many lytic studies that have been done in the submassive PE group. It's important to note, though, that we only recently began classifying patients as having either high risk submassive versus low risk submassive. And all of these studies did not discriminate, with the exception of PYTHO, did not discriminate between high risk submassive and low risk submassive. So meaning all submassive patients were included. And that'll become relevant, I think, when we start teasing at why we found some of the results that we have, and perhaps why we hadn't in those individual groups seen quite the mortality benefit that had been expected. So going through a few of these, the MAPIT trial looked at alteplase versus heparin in patients with submassive PE. Again, these were all submassive PEs. And their primary endpoint was a combined endpoint of death from all causes and then escalation of treatment. And you can see here how they defined escalation of treatment. So the primary endpoint was met in the thrombolytic group. And there was a statistically significant difference between the alteplase group versus the placebo group. However, that was predominantly driven by escalation of treatment, meaning those patients needed some sort of rescue, and that rescue was defined as levofed infusion, secondary thrombolysis. They needed mechanical intubation, CPR, or embolectomy or thrombus fragmentation. And that escalation of treatment was predominantly driven by secondary thrombolysis. And this will become relevant when we see the updated CHEST guidelines. Important to note that there were no fatal bleeding or hemorrhagic stroke in the alteplase groups. TOPCOAT was a unique study in that it looked at tenecteplase versus placebo in patients with submassive PE. Again, these were all comers with PE. They were one of the earlier trials to use low molecular weight heparin as the anticoagulant of choice after patients received their intervention. And they looked at a combined primary outcome of death, shock, intubation, major bleeding within 5 days. But importantly, because there had begun to have been this recognition about functional limitations in patients after who have had acute PE, they looked at not just recurrent PE, but poor functional capacity and quality of life scores at 90 days. And what they found was that the tenecteplase group did better than the placebo group when it came to their primary outcome. HI-PYTHO was the most recent and largest clinical trial that looked at 1,005 patients. And what was important about this trial was that they really did try to enrich the study population, looking at patients who had not just any submassive, but really high risk, what we now call high risk submassive PE. So these were normotensive patients with RV dysfunction on echo or CT and myocardial injury. And that was defined as a positive troponin. And again, they looked at heparin plus tenecteplase versus heparin plus placebo. And their primary outcome was a combined primary outcome of death from any cause and hemodynamic decompensation. And the primary outcome was met. However, you will see that it was predominantly driven by a reduction in hemodynamic decompensation rather than death from any cause. It's very, very difficult to power PE studies for mortality. And so that's why you're often seeing these combined primary endpoints. The risk of major bleeding was certainly higher in the thrombolytic group in the PYTHO study. There was more intracranial hemorrhage and less recurrent PE, which would be expected. However, if you break down this major bleeding and intracranial hemorrhage into age groups, you'll find that it was the over 65 age group that had more of the major bleeding, but that really evened out in the less than 65 group. And so it really does kind of, I know for our practice, raise our alarms a little bit when we're considering giving thrombolytic therapies, honestly, whether it's in submassive PE or massive PE, thinking about that age cutoff, that risk of intracranial hemorrhage is higher in that above 65 age group. An important difference between these studies, so this was an analysis that looked at the raw data of all of the thrombolytic studies that we've had in PE, and really trying to dissect if the differences between alteplase and tenecteplase. And what you'll find is that if you look at all the alteplase versus placebo trials, and you look at the intracranial hemorrhage rate, in the heparin, heparin plus placebo group versus heparin plus lytic group, you'll find it was only around 0.4%. The tenecteplase group or the tenecteplase studies are the ones that show us that 2% intracranial hemorrhage rate. And so choice of agent, I think, makes a very big difference when we're thinking about intracranial hemorrhage risk in the setting of administration of systemic lytics. With tenecteplase certainly seeming to confer a higher risk of bleeding than alteplase. This was a meta-analysis that pooled all of the studies looking at thrombolytic therapy in submassive PE versus anticoagulation. And you'll see that looking at all of those together, once the PYTHO trial was published, there was mortality benefit favoring thrombolytic therapy in this patient group, or in this patient population. So what do the guidelines say about thrombolytic therapy in submassive PE? CHEST initially started off saying no, and in 2019, in 2009, but then more recently, when they revised their guidelines in August 2021, they changed their tune a little bit. And so in selected patients with acute PE who deteriorate after starting anticoagulation therapy but have yet to develop hypotension and who have an acceptable bleeding risk, we suggest systemically administered thrombolytic therapy over no such therapy. So that's that patient who started off okay, but then began to deteriorate. And deterioration is kind of vaguely defined. So they just say a decrease in systolic blood pressure, increase in heart rate, worsening gas exchange, signs of inadequate perfusion, worsening RV function, or increasing biomarkers, cardiac biomarkers. And such deterioration should prompt consideration for thrombolytic therapy in the absence of frank shock if the bleeding risk is deemed acceptable. And so that, I think, was a huge shift for CHEST, who again, tend to be more conservative than the ESC, for example. So why has it been so difficult to find answers in the submassive PE population? Most studies included all submassive PE without discrimination between high-risk submassive versus low-risk submassive. Again, that's with the exception of the PYTHO trial. They are a very heterogeneous patient population, and we need to do better in terms of refining which of these patients we think may benefit from more advanced or aggressive interventions. It's very difficult to power studies for mortality as a primary outcome due to low event rate. And this perhaps could begin to be overcome with enrichment of our study populations. And mortality isn't the only important outcome in this patient population. Persistent RV dysfunction resulting in exercise intolerance leading to impairment of quality of life is very important. And as you'll see in later talks today, post-PE syndrome is a very real problem in this patient population. And having RV dysfunction at the time of initial diagnosis certainly confers that higher risk for its development. So in summary, systemic thrombolytic use in massive PE is supported by all major society guidelines. The presence of RV dysfunction is an independent risk factor for higher 30-day mortality in PE and is associated with worse long-term outcomes. Consideration of systemic thrombolytic can be given in patients with submassive PE that are at high risk or experience clinical deterioration. And better identification or characterization of patients with high-risk submassive PE that may benefit from reperfusion therapy is needed. We're soon set to begin enrolling patients in the HiPytho trial, which is a randomized control trial looking at catheter-directed thrombolytic therapy versus systemic anticoagulation in high-risk submassive PE. So I think it's a much needed, much awaited trial, and we're really excited to be a part of it. And with that, I will wrap up. Are there any questions? Okay. I think next up is Dr. Koenig. Is Gerald
Hi, Sarah.
here? Oh, yeah. Okay.
Can you hear me?
Yes. Mm-hmm.
All right, great. And can you see my screen?
Yes.
Okay, great. Well, thanks very much for the opportunity to speak with you today. And I'm going to talk about the thrombolytic treatment of acute PE utilizing both systemic and catheter-based approaches. Sarah's had an overview of some of the trials and information we have pertaining to these, as well as the guidelines. And as an interventionalist in cardiology, and this pertains to our interventional group in radiology too, this plays a vital role in our decision-making process as part of the PERT team. My disclosures here have no real relevancy towards this presentation today. As we've already heard from the group, we know that PEs are, a very significant leading cause of cardiovascular mortality, ranking third so far with at least over 100,000 every year. And I won't get into the further details pertaining to that, as already been described. But essentially, the timely diagnosis is essential and appropriate risk stratification. And Scott went nicely through the process of doing that, not only through PESI and SPESI scores, but additional risk evaluations. And then stratifying, obviously, the degree of a PE from a non-massive category to the submassive and massive, and then within the submassive to also breaking those into intermediate high and intermediate low risk categories. And those have significant differences in short and long-term outcomes, both in mortality as well as morbidities. And it's really in this massive and submassive category that we find the lytic therapy is playing a significant role compared to just anticoagulation with unfractionated heparin. The general algorithm has already been described in classifying and going into a risk stratification into the high and intermediate risk categories, and then the subsequent risk-based management strategies in the lower portion of the screen here in terms of anticoagulation and consideration for thrombolytics and reperfusion therapies fall into the intermediate high risk and high risk PEs. Now, in starting with the high-risk massive PE category, obviously the first and foremost management is the hemodynamic and respiratory support, and then early anticoagulation with unfractionated heparin, and then a consideration towards primary reperfusion. And that's either systemic thrombolytics or a catheter-based percutaneous approach with thrombolytics. And then finally, also consideration for surgical embolectomy, especially in those individuals who are contraindicated towards thrombolytics or have failed thrombolytics. And then the intermediate risk or submassive PE, anticoagulation again, but these can also be anticoagulated with low molecular weight heparin or fondoparinox. And then, as mentioned, the further risk stratification into that intermediate high group versus the intermediate low group. And that includes higher classification within the PESI score system from 3 to 5. And then the evidence of an RV strain or dysfunction, either on imaging by CT or echocardiography and or by biomarkers, more so within the troponin classification as opposed to the BNP status. Thrombolytic therapy as a mainstay for treatments in massive PE and consideration in the intermediate high risk offers the rapid onset of action, reducing directly the thrombus burden and restoration of the pulmonary perfusions and capillary blood flow, allowing improved gas exchanges. And generally has a 90% favorable response. Greatest benefit is in those individuals receiving treatment within 48 hours. And of the thrombolytics, the first generation classification, which really is not utilized in the United States at this point, are streptokinase and urokinase, and early studies, which I'll touch base on in a moment, utilize these thrombolytics. And then the second generation, namely the TPAs and tenecteplases, with TPA having FDA approved treatment in acute PE in the United States. Contraindications towards fibrinolysis is obviously essential. Big risks involved is intracranial hemorrhage and hemodynamically significant bleeding, as well as the need for blood transfusions. But the absolute contraindications, just serving as a reminder for everyone, are prior history of intracranial hemorrhage or hemorrhagic strokes, known structural intracranial cerebral vascular disease or neoplasms within the last 3 months, having an ischemic stroke, on presentation suspected of having an aortic dissection or any active bleeding diatheses, recent spine or cranial surgeries, closed head injuries or traumas from their presentation, or any major trauma within the last 3 weeks. And then there are a host of relative contraindications, which is usually an accumulation of at least 2 or 3 of these individual topic areas to consider holding off on thrombolysis. And so in looking at the data for systemic thrombolysis, I'm going to start with the massive PE category. The first study published in 1970 was the PERT study, looking at about 160 patients, 14 of which were classified at that time as high risk. They compared urokinase versus heparin, and they utilized lung scans, pulmonary angiograms, and right heart pressures, and followed them at a 24-hour mark, and they showed significant improvements in the outcomes in the urokinase group. At 30 days, there was no difference in the mortality rates compared to heparin. A few years later, a second study came out that was prospective and randomized, looking at 30 patients and utilizing streptokinase versus unfractionated heparin, and looking at acute or progressive life-threatening PEs, largely those individuals who had a diagnosis well over 6 hours. They too saw significant improvements in pulmonary embolism resolution by both angiographic score and by hemodynamics in measuring PA pressures. And then it took several years, nearly 20 years, for this study to be published. And interestingly enough, Rosas's group, they looked at a prospective randomized control trial. Only 8 patients were enrolled in this study, just 8. And they looked at streptokinase and unfractionated heparin. They had similar degrees of hypotension, duration of shock, PA pressure elevations, and RV dysfunction. And in this study, all 4 patients who received the unfractionated heparin had died within 1 to 3 hours. All patients who were treated with streptokinase improved within an hour, all survived, and in 2 years were without any pulmonary hypertension. This really set the precedent and set the guidelines towards massive PE receiving thrombolytics in a systemic fashion. And it's such a small trial. Subsequently, meta-analyses a couple of decades later and utilizing 15 historical randomized trials, including over 2,000 PE patients, demonstrated that in acute PE, the utilization of systemic thrombolysis demonstrated consistently lower all-cause mortality, lower PE-related mortality, and lower indices of recurrent PEs. And this is just a slide demonstrating the 15 trials over the years and the different thrombolytic agents utilized, as well as duration of follow-up. In breaking it down, they found that the systemic thrombolysis only had significant reductions in combined endpoints, namely death and treatment escalations, as well as PE-related mortality and PE recurrence, was in the intermediate and high-risk PE groups, and there was not significant within the low-risk PE categories. So intermediate and intermediate high-risk groups are the ones that demonstrated statistical significance in the meta-analysis and thereby included in the guidelines now for systemic thrombolysis treatment. The adverse outcomes, however, there was a significant increase in major hemorrhages and greater events of fatal and intracranial bleeding. Now, these were most commonly found in the tenecteplase and urokinase and streptokinase. And in fact, it was the least within the TPA or alteplase classification. And so hereby is where the alteplase or TPA received the FDA approval to be the choice of thrombolytic in the United States. Well, with the higher doses of thrombolysis, namely the standard is for TPA 100 milligrams over a 2-hour time course, there was consideration in terms of lowering the bleeding risk by giving less thrombolysis and in decreasing it by half, by 50 milligrams over a similar time course. So this trial looked at those individuals in 118 patients, and they showed similar progressive improvements in the RV size, lung perfusion defects, pulmonary artery obstruction scores, and found no significant differences within the mortality. And they found less bleeding, particularly in the low body weight groups. And so this kind of set the precedent for consideration towards 50 milligram dosing instead of the 100 milligram dosing, receiving similar efficacy. Now, as far as submassive PE and systemic thrombolysis, the main contemporary trials looking at full dose lysis was within MAPIT-3, PITHO, and TOPCOAT, some of which has already been covered by Sarah in her talk as well, but also in the reduced lysis groups, looking at the PIOPED and MOPIT studies. So in MAPIT, they looked at 256 patients. They randomized, double-blinded, submassive PE, systemic TPA versus heparin. And they found significantly higher events in the heparin group, nearly 25%, versus the TPA group, 11% on the primary endpoint, which was in this case in-hospital death or clinical deterioration requiring escalation of treatment. Higher 30-day event-free survivals was found in the TPA group, and no significant difference within the fatal bleeding or cerebral bleeding was identified. In the PITHO trial, again with intermediate risk, this was a European-based trial looking at nearly 1,000 patients, double-blinded, randomized. This time it was tenecteplase versus heparin, and their conclusion was tenecteplase prevented hemodynamic decompensation in providing one of their primary outcome measures as statistically significant. Unfortunately, it showed an increased risk of major hemorrhage and stroke events. Again, this was in tenecteplase and not utilizing alteplase or TPA. Similarly designed trial was Topcoat, only looking at 83 patients, but only in the US. Again, tenecteplase systemically given versus unfractionated heparin alone. They demonstrated that tenecteplase resulted in fewer combined adverse outcomes: death, shock, intubation, major bleeding, functional capacity, and recurrent PE within 5 days compared to heparin. And then looking at reducing the dose so that not as much bleeding complications arose, PIOPED came along. The initial study only being of 13 patients back in 1990 and randomized to double-blinded individuals. The systemic TPA was reduced to 40 to 80 milligrams IV versus unfractionated heparin. Here they used angiographic scores and mismatched perfusion defects and found them to be similar between the groups at 2 hours, but trended towards improvement at 24 hours. There was a significant reduction in the vascular resistance within the pulmonary bed for those receiving TPA, but there was similar PA pressures between the two groups and only one significant bleeding event. Finally, MOPIT, again, looking at the reduced dose, this time looking specifically at 50 milligrams IV versus unfractionated heparin and about 120 total patients. They found significantly less pulmonary hypertension or the combination of pulmonary hypertension and recurrent PE in the TPA group. No significant difference in total mortality, overall being relatively low. And with a relatively low percentage of patients, not a high power indice was evident in this study. And there was no significant bleeding events associated with the utilization of the lower dose TPA. Meta-analyses of 5 total studies covering over 440 patients, and the low dose TPA being categorized as either 50 milligrams IV or a 0.6 milligrams per kilogram versus the standard dose of 100 milligram of TPA. Major bleeding events in standard dose TPA groups was higher than in the low dose group and statistically evident. And no statistical differences were found in recurrent PE or all-cause mortality. So demonstrating efficacy while reducing the number of bleeding risks. So it should be a consideration in our treatment courses nowadays to consider lower dose forms, either by weight base or by half dosing of the standard. As far as catheter-based thrombolysis, the categories of dividing into massive and submassive are much grayer. Many of the studies are either mixed or focused on the submassive PE category. The benefit of catheter-directed thrombolytic therapy is that it can be a very selective continuous infusions and not have as significant of a systemic effect. And with the local application, potentially dissolve the thrombus and achieve a more rapid reperfusion, resulting in improvement in the hemodynamics in a faster manner, normalization of the RV size, and reduction of the PA pressures and oxygen requirements, and also potentially reducing the risk of bleeding complications. Major studies looking at catheter-directed thrombolysis are the ones listed here: Ultima, Seattle 2, and Optilase, all of which utilize this ecosystem, which is very common for us to utilize and was mentioned in Sarah's talk, utilizing an ultrasound accelerated or ultrasound assisted catheter-directed thrombolysis mechanism. And then looking at the PERFECT study, as well as Sunset SPE we'll talk about as well in terms of different catheters directing thrombolysis outside of ECOS. And then finally, looking at long-term outcomes related to ECOS versus unfractionated heparin in the currently beginning trial of HI-PEITHO. So the Ultima trial was 59 patients, all intermediate risk, randomized to the ultrasound facilitated thrombolytic catheter-directed system called ECOS versus a standard unfractionated heparin given systemically. They saw a significant reduction in the RV enlargement at 24 hours, as well as a significant reduction in the PA pressures. And at 90 days, they saw a greater reduction in RV dysfunction, meaning improvements in RV function compared to unfractionated heparin. There was no adverse effects in utilizing the catheter approach, including no serious bleeding events. Seattle 2 subsequently came along, 150 patients. This was only a single arm, but prospective, looking at both submassive as well as the third being massive PEs in the main or segmental PAs with RV strain evidence and utilizing ECOS alone, not comparing it to any unfractionated heparin, and that the symptoms were within 14 days of onset. Here they showed improved RV function with reductions in RV-LV ratios, reduction in angiographic levels of obstruction, decreased pulmonary hypertension, particularly evident in the intermediate to high-risk PE groups, and no evidence of intracranial hemorrhage, unlike in systemic lysis, which has upwards of 2.5% to 3% of individuals at risk. These are just some of the diagrams that were presented within the studies demonstrating the reduction in the RV-LV ratio as well as the PA pressures, and then the degree of thrombotic obstruction by utilizing a standard mean modified Miller indice. In specifically looking at massive versus submassive PE groups, RV-LV ratio improvement was similar in utilizing ECOS, meaning PA pressures were also similarly improved, but massive PE patients were more likely to experience major bleeding compared to submassive PEs, likely the result of their the severity of their illness on presentation. Should be noted that bleeding complications do exist. They may not be any intracranial hemorrhages, but upwards of 10–11% of significant bleeding, major bleeding categories are evident within 30 days of utilizing the ECOS system. So it's not without any bleeding complications. And so with that setting, they looked at a trial designed at reduced levels of thrombolysis and duration. So total dosing as well as the duration of the lytic therapy. Standard was nearly 24 milligrams with about 1 milligram per hour being administered on average per catheter. It had been in Seattle 2 and in Ultima. This looked at 4 different categories and overall ranging between 8 and 24 milligrams of TPA were being given, either in group 1 over 2 hours or in group 4, which is close to the standard of treatment, arising over 6 hours. And what they found was that all the cohorts were equivalent in reducing the amount of RV strain by RV-LV ratios, namely about 25% reductions. And these were similar compared to the historical studies within Seattle 2 and Ultima. And they had a low bleeding rate of only 4% within 72 hours compared to the 10–11% found in Seattle 2. And this is demonstrated in the diagram on the left side in terms of the RV-LV ratio improvement compared across the different cohorts. with the left cohort in the kind of bluish green being the lower dose and shortest time period, compared to the green being the highest dose over the longest time period. On the right side was a very interesting portion of this study, again demonstrating the RV-LV ratio diameter improvements or changes that were evident over the time course between the different arms, and that's shown in orange. That is basically the same across the different groups, and that's despite the differences in the TPA dosing, which you can see were 8, 8, 12, and 24 through the different arms. So increasing the TPA didn't provide any change in the RV-LV diameter ratio improvement. But what they did find was when they looked at the revised modified Miller score for the degree of thrombotic burden evident on CT imaging, that was directly proportional to the TPA dose, but didn't correlate with the improvements in the RV-LV diameter. The thought is, it doesn't take a lot of improvement in the thrombus burden to make a significant difference in PA pressures as well as the strain placed on the RV. So having a meticulous extraction of all the clot or a large percentage of the clot is probably not necessary and just subjects the patient to added risk, including bleeding complications, while not necessarily providing a significant difference, at least as it pertains to the RV strain. Currently enrolling is the High Pytho trial, and we're a planned site for participation in this. And this is going to more definitively assess ECOS versus unfractionated heparin over a much longer course and looking at primary outcomes of mortality, PE recurrence, as well as development of cardiopulmonary decompensation within a group of intermediate high-risk patients alone. And they're going to be followed over a 12-month time period. We're planning on enrolling over 400 patients at 60 different sites in the United States. So this should really give us a lot of good data that we can compare truly, do these catheter-directed thrombolytic therapies significantly improve outcomes compared to heparin alone over a longer time course and with different measures outside of hemodynamics and RV strain patterns. A lot of questions come up with respect to, do we really need ultrasound to enhance the effects with the ecosystem, or can we just put a catheter in there and drip in lytics and get an equivalent response? So a couple of studies have looked at this, not a large percentage of patients. This one, the PERFECT trial, had 100 or so patients, looked at both massive and submassive PE categories in a 1/4 to 3/4 ratio. They were treated with a catheter-directed mechanical or a mechanical pharmacothrombectomy device versus or in combination with ECOS, utilizing TPA or urokinase. And either methodology has achieved a high success rate in massive PE, over 86%, and they achieved a high success in submassive PE, over a 97%. And success was deemed by stable hemodynamics, improving pulmonary hypertension and RV strain, and survival to discharge from hospitalization. There weren't any documented major procedural related complications, including major hemorrhages or strokes involved with utilizing these catheter directed approaches. And mean PA pressures improved with either device in a similar degree. However, if you look at the distribution, which is shown in the right category, separating out specifically those patients treated with the ultrasound assistance versus just a catheter-directed thrombectomy approach. The far right shows that there's a greater percentage and a narrower distribution of the pressure improvements in the pulmonary system compared to just a standard catheter-directed approach. The Sunset SPE trial helped address this even further by looking at roughly 81 patients in a randomized single-blinded study. Again, ECOS versus a direct standard catheter to administer thrombolysis. And here they looked at a primary endpoint of thrombus reduction on CT imaging utilizing the Miller scoring system, and they found no difference in the outcomes. And as far as secondary outcomes, they found a greater change actually in the RV strain by RV to LV ratio in the standard catheter-directed thrombolysis compared to the ultrasound. So kind of opposite of even what would be anticipated or possibly expected, that you got a better outcome with not utilizing ultrasound in terms of the RV-LV ratio. ICU stay also tended to be trending towards a lesser number of days utilizing the standard catheter as opposed to the ultrasound assisted. Critics of the study reported that the power of the study was inappropriate and was not able to really demonstrate these secondary outcomes in a statistical manner that was applicable towards clinical usage. And so larger studies are recommended. And in fact, there is one coming up either later this year or next year that we'll be enrolling, and likely we will be part of that as well to really answer this question, because an ECOS catheter system versus a standard catheter system is a large difference in terms of the monetary involvement here. As far as guidelines in the thrombolysis, Sarah covered this really well. I'm not going to get into this, but generally, you know, for the MASAPs, we're looking at systemic thrombolysis and less so in the intermediate risk categories. Intermediate risk, we're looking for utilizing a more focal catheter-directed approach towards treatment. And that's evident also in the European Society of Cardiology, as well as the updated ACC guidelines. And then, of course, as Sarah covered, in the American College of Chest Physicians as well. There are newer thrombolytic drug options being developed and actively studied in early phase trials, either a thrombin activatable fibrinolysis inhibitor, or a modified recombinant microplasminogen, or a layer by layer nanocapsules are being explored and studied, and maybe future avenues for treatment for individuals instead of our tried and true and crude thrombolytic therapies that we have right now. That's the end of my talk today. I'm happy to answer any questions that people have pertaining to the utilization of systemic or a catheter-based thrombolysis approach to treatment of PE. Thank you.
Thanks so much, Gerald. That was great. Does anyone have any questions? Okay, I think we will keep moving. Next, Dr. Scott Schwartz from Interventional Radiology is going to talk to us about catheter thrombectomy, candidate selection and treatment.
Sorry, I was just trying to find my unmute button. All right. Thank you, everyone. My talk is going to focus more on catheter thrombectomy. I do not have any disclosures. This talk, in contrast to Dr. Koenig's, is not going to have a lot of clinical studies, unfortunately, because for this type of treatment, there is not great high quality data yet. The history is that surgical embolectomy was first conceived in 1908 and first performed in 1924. There's been many advances since then, but the perioperative mortality for massive PE is still about 20%, and it's still pretty invasive and has a long recovery period. As far as catheter-directed techniques, things first started out with, as Gerald was saying, putting a catheter out into the pulmonary artery and injecting thrombolytics with or without spinning this pigtail catheter in the proximal pulmonary artery branches to fragment the clot into smaller pieces. You can also put in a balloon that can macerate the clot against the arterial wall. Then newer advances were in rheolytic thrombectomy. If some people have heard of angiojet, which is used in the peripheral vasculature. And this uses forceful pulse spraying of TPA via a catheter directly into the thrombus. And then the machine switches into suction mode where it uses this high pressure saline jet and a low pressure zone behind it to aspirate all this lysed clot. It was used for pulmonary embolism back in 1997. However, there was about up to a 25% mortality with this procedure, and mainly due to the release of adenosine from disrupted platelets causing bradycardia and pulmonary vasospasm and hypoxia. And now there's actually a black box warning to not use this for pulmonary intervention. So nobody uses this anymore. There's many aspiration thrombectomy devices. They're used for many different areas, some pulmonary, some neuro, some peripheral vascular. Most of the devices that you see on the screen here are used in more small vessels. These are either stents or corkscrew devices that lodge the clot within the stent, and then you retrieve them through a catheter. Unfortunately, they're just very small bore, so they don't have a lot of utility in the pulmonary arteries. Some of the aspiration thrombectomy devices, there's some that aren't available to us outside of the, inside of the US. There's something called the Aspirix catheter, which just rotates at high velocity and fragments the thrombus and pulls it out. There's various devices that were used for hemodialysis fistula declots. But again, there's limited experience with this in the pulmonary arteries. And again, they're very small size, so they're not of great utility. There was something called the Greenfield embolectomy catheter, which was a medium-sized 10 French steerable catheter, which had a suction cup on its end, and you could aspirate out clot, but you couldn't really do this over a wire. It wasn't very easy to use, and again, it had a pretty high mortality. Probably about, I'd say maybe 10 years ago, a device called AngioVac came on the market, and this was one of the first large bore devices that could be used to suction out large volume thrombus. For those not familiar with the system, what it is a very large 22 French catheter. And it's a suction catheter which gets hooked up to a cardiopulmonary bypass, basically, and it acts as a dialysis machine. So you're sucking blood from one location, you're putting it through a filter, and then it gives it back through another venous access. So you divert about 3 to 4 liters of blood per minute. The clot gets stuck in a canister, and it works pretty well. However, for pulmonary arteries, it's a little bit difficult. The first technical aspect is that it is not a transitionless system, so you have to drag across fairly big leaflets through the valves, and you can cause significant damage. The other thing is that it's a pretty stiff system, and it's somewhat difficult to get up to the pulmonary arteries. The last problem with it is that you're diverting a significant amount of RV output, and it's not very well tolerated in people who already have tenuous RV function. There's some other devices. One is a Penumbra Indigo that recently was approved for larger size aspiration catheters. They now offer up to 12 French. This is basically just a long aspiration catheter that is attached to a suction pump. The problem with it is, despite being larger bore than what we used to have in the past, 12 French is still not very large when you're dealing with the thrombotic load from pulmonary embolism. Then probably maybe 6 years or so ago, another device called the Inari FlowTriever came on the market. This received 510K clearance for pulmonary embolism. And its approval was based on one trial, which was a prospective single-arm multi-center trial with 106 patients in 18 sites. They did follow-up at 48 hours and 30 days, and their primary endpoint was to, number one, check the effectiveness and reduction of the RV-LV ratio at 48 hours. And then the other was to determine the safety of the device. We'll talk a little bit about that later on. So this device has two components. One is a 20, actually now they come up to 24 French catheters, and it's just a long aspiration catheter, but it's pretty flexible. And again, it has a nice transition. It's transition-less, that it's easy to get up to the pulmonary artery. The second part of this is a device that goes through this catheter, and that's the small ball that you see on the end of the catheter, and that can be used to engage clot and pull it into this suction catheter. The reality of this is, when you're working in the pulmonary arteries, and actually most elsewhere, the only part that you use is the aspiration catheter. The catheter now has become large enough where you don't necessarily need this other device to remove more clot. One of the downsides to this was that because you're sucking thrombus through a 20 or 24 French catheter, you tend to have a lot of blood loss. And that was pretty rate limiting step, especially in the pulmonary circulation when you're removing 60 cc's of blood at a time. And in the past year or so, they came out with a new device that helps filter this blood loss. So you aspirate blood or clot through the suction catheter, and then you hook it up to this filter and push the blood through it, and it traps the clot within this 40 micron filter. And then on the other end, you have a syringe that takes the blood, the filtered blood, and then you can re-infuse that into the patient. So that's really changed things a lot, because when we used to do this, we used to worry about how many passes we could actually make safely when we're getting a half a liter of blood loss. And now we're really not limited in the amount of aspiration that we can do, because we know that our blood loss is going to be maybe 50 milliliters per case. So we'll go through a couple of cases here. Case number one is a 73-year-old female. She has prior pulmonary embolism, but she's no longer on anticoagulation. She presented shortness of breath times 1 week. She was hypoxic on room air and tachycardic on presentation, and her EKG showed a S1Q3T3 complex. She got a 2D echo. She had a severely enlarged RV, moderately reduced RV function, and it showed a D-shaped septum and systole and a McConnell sign. Her CT showed large burden of thrombus in the central pulmonary arteries and all the segmental branches. And here is coronal reformats where you can really see the extent of the thrombus. She went to pulmonary angiogram, and you can see similar findings with the large kind of saddle embolus going between the upper and lower lobe arteries. And this really highlights where the mechanical thrombectomy devices are very beneficial for very proximal large volume clot. As you see in the image, this is actually a 20 French catheter, and now they come larger at 24 French. And you can't really get these catheters out into the small subsegmental branches. So it's really the central saddle and proximal segmental branches that you're aiming for. So here's the pre-CT, and then afterwards, you can see the pre and post. So you can really take out a large volume of thrombus. And the other advantage to this is that, well, actually, we'll get into that later, but this is the left side, and then this is a picture of what was taken out during that procedure. Repeat echo showed normal RV size, normal function, and a normal pulmonary artery pressure. Case number 2 is a 66-year-old male, past medical history of hypertension and a prior pulmonary embolism 10 years ago, had a recent drive from Florida and calf pain times 1 week, then became short of breath for 1 day after working out at the gym. He had bilateral segmental pulmonary emboli. He had evidence of strain on CT with an RV to LV ratio greater than 1. He had an elevated troponin. His vitals were stable, and he was satting 94% on room air. Didn't have any contraindication to catheter-directed lytics. But the 2D echo that was done showed a mildly enlarged ventricle and mildly reduced function. However, there was a large swirling thrombus in the right atrium, which was intermittently passing through the tricuspid valve. So for this patient, we were less concerned about the burden of PE because he really didn't qualify for any thrombolytic or advanced treatments. We were more concerned about the RA thrombus in transit. So we made the decision to pursue catheter embolectomy for this patient. Here you can see the thrombus within the RV crossing the tricuspid valve. And this next slide, hopefully the video plays, but you can see this thrombus swirling around in the right atrium. So this one, we actually used the device that we talked about earlier, which was the, not the FlowTriever, but the AngioVac. And what you see here is the clot that was in the RV, and now you see it's no longer, there's a pretty clean valve. Case number 3 is a 65-year-old gentleman who was recently diagnosed with small cell lung cancer. He came in with shortness of breath, fatigue, and syncope over the past 5 days, was hypoxic and hypotensive. He had a lactic acidosis and his troponin was elevated. CT shows very large burden of thrombus, again with a saddle pulmonary embolus. Extending into both main pulmonary arteries and all the segmental branches. His echo showed severely reduced function and pulmonary hypertension. But the problem with him is his newly diagnosed small cell lung cancer and brain metastases. So he was brought for thrombectomy. And as you see on the top left image, there's an enormous amount of thrombus burden throughout all of the visualized pulmonary arteries. And then after catheter embolectomy, you can see that he has pretty clear pulmonary arteries. There's still some non-occlusive segmental clot within the upper lobe branches, but it's drastically improved from pre-procedure. Here you can see the left pulmonary artery with a significant degree of thrombosis, which improved on follow-up. This is a picture of the thrombus that was taken out, and you can really see the cast of all the pulmonary arteries. Repeat echo showed normalization of his RV function and resolution of the pulmonary hypertension. So pretty much when we talk about catheter embolectomy now, most institutions are talking about using one device, which is the Inari FlowTriever. Now, this isn't universal among all institutions. There are some people using those smaller devices that I talked about earlier up in the pulmonary arteries. But it really does take a lot longer because you're dealing with a smaller catheter. And most institutions have really adopted the FlowTriever. As I said before, this was approved based on one study called the FLAIR study. It was a prospective study And again, they looked at the primary endpoint being a change in the RV-LV ratio at 48 hours. What they found was that there was significant reduction from baseline with the FlowTriever device, which was similar to results that were seen in the catheter-directed lytic trials that Dr. Koenig had shown before, and it was better than anticoagulation alone. There was no incidence of intracranial hemorrhage or major access site bleeding or device-related injuries. There was a 3.8% adverse event rate. 4 patients clinically deteriorated. 1 had a major bleeding event and 1 had a major pulmonary vascular injury. The bleeding event was, I believe, localized in the chest from the pulmonary vascular injury, but it wasn't an intracranial hemorrhage. They had a mean procedure time of about 1 hour and 40 minutes, and they had a 1-day average ICU stay, and 42% of those patients didn't spend any time in the ICU. So that's a real big difference from the catheter-directed lytics, because once they go on the catheter-directed lysis route, these patients are obligated to be monitored in the ICU until those infusions stop. With this catheter embolectomy, we can potentially avoid sending the patients to the ICU. The limitations of this study was that, it wasn't randomized, there was only 1 arm, and they only had measured short-term outcomes, and they only studied, intermediate risk PE with proximal burden of thrombus. So really, why do we even talk about using this device? Well, number one, we know that for massive PE that the mortality rates are very high. For intermediate risk PE, 10% of those are going to have hemodynamically significant RV failure. We need to rapidly reduce the RV afterload. Some patients have contraindications to thrombolytics, as we saw with the patient with brain metastases. Some people are clinically deteriorating rather rapidly and cannot wait for the catheter-directed lytics because those have to dwell for at least an intermediate time. As Dr. Koenig had shown earlier, there are some studies showing that there is benefit to doing a little more rapid infusion of lytics. There are some patients who are high risk for surgery, and then there's some people with right heart thrombus. And if somebody has a right heart thrombus and has pulmonary emboli that need to be addressed, it makes more sense to do the catheter embolectomy than it would for us to do the catheter-directed infusions. So really, for massive PE, should there be a paradigm change instead of going to surgery for these? There's still a 20% surgical mortality, and there's a 20% major bleed rate with systemic thrombolytics. Systemic thrombolytics also have to infuse over a period of time. 10 years ago, we wouldn't be having this conversation, but now there's less invasive percutaneous options, which can really rapidly reduce these massive burdens of thrombus within the pulmonary arteries. But like I said at the onset of this talk, we really lack good data for, number one, who is a good candidate for this, and is this really better than any other treatment, for instance, the catheter-directed lytics. There are some institutions that have now replaced catheter-directed lytics with catheter thrombectomy, but unfortunately, we just don't have great data to support that other than anecdotal evidence. But you are seeing a lot more of this being done lately. That's all I have. I'm happy to entertain any questions.
Thanks so much, Scott. I actually have a question for both you and Gerald. Just kind of what you were alluding to now, do you think that we're going to see, with the better safety profiles that we're seeing with mechanical thrombectomy, are we going to see a similar shift in PE that we saw, for example, with stroke and STEMI, where we are going to be shifting more towards reperfusing by removing whatever the obstructive lesion is, and in this case, using a mechanical device to extract it, as opposed to trying to lyse these very large clots?
Well, I'm interested to hear Gerald's take on this. My answer is yes and no. I think that the devices have great potential and they work very well. But again, a lot of the advances that you've seen with neurointervention and thrombectomy happen with trials, and it took a long time, and they now have good evidence to suggest that this is very good. Right now, we don't have that evidence, at least for the catheter thrombectomy.
Yeah, I think, and correct me if I'm wrong, I think Inari is going to, isn't the Peerless study going to be catheter directed versus mechanical thrombectomy? Or
yeah, there are some studies upcoming. The question, the real problem that came about with this device is that things have shifted so much in the past couple of years, and standards of care and practice patterns have really changed, where we were just starting to get a good grasp on the data for catheter directed lytics, and then this device comes along and people are starting to shift focus on that. So it's a pretty rapidly developing field. Gerald, what's your take on it?
Yeah, so, if we look at it from some of the cardiology studies in the coronaries and so forth, for instance, a thrombectomy device within most of the coronary arteries in an acute MI don't yield better outcomes. However, we are ballooning and we are stenting to open up that blood vessel. So we are doing some type of intervention. The second thing is in neuro and in our studies, in cardiology, those are much smaller catheters. We have very large catheters going into the PA system. Now, granted, they're on the venous side and not on our arterial side, but it's not without potential of some complications associated with utilizing such large catheters. Third, I think that the evolution is going to be that they're going to use a smaller profile for insertion, and they're going to be expandable devices once they're into the PA system, like a large funnel or desheathing that's going to be nitinol based, expanded open, so you get a bigger volume area, but access point is going to be smaller. And that type of technology, I think, will really make a difference. And then we're going to go towards more of a mechanical or invasive approach than just doing anticoagulation for these higher risk patients, and definitely not the lysis. I think we are going to go that way eventually because of all the complications associated with it. It just needs still a little bit more maturity in the technology we're using. And we're already seeing promising results even with the current technologies. So.
Well, thank you. Thank you both. Does anyone else have any other questions? Okay. So next, we could do this one of two ways. We're about 15 minutes ahead of schedule. Do you guys want to take a break for 10 minutes maybe and reconvene, or would the group prefer that we keep going? Daniel, what do you think?
Dr. Agave, I think we can do just a brief interval, like just a 10-minute, and then reconvene. Okay,
let's do that then. So it's 1:45 now. We'll reconvene at 1:55, and then we'll hear from Dr. Grafton.
Sarah, are you the host?
Yes, but you should be too.
It says I can't host disabled participant screen sharing.
Oh, let me see. I'm not sure that I can grant you that. I think Hashmi has to do it. Hashmi, are you there? Oh, he just texted. He just messaged he's going to do that now. I don't see that you have it yet. I don't know, did it change for you?
No.
Okay, it should work now, Jillian. All right. I hope everyone got a little bit of a break. And so next up, Dr. Grafton's going to talk to us about mechanical circulatory support in PE as one of the tools in our armamentarium in treating these high risk, very sick patients.
Thank you, Dr. Hagab. This presentation shouldn't be too long. Unfortunately, we don't have a ton of mechanical support that we have available for these patients with PE. And really, as you've learned already, the main treatment is reperfusion and really rapid care. But we'll kind of talk about a couple of the options and a little bit more about our thought process of who and when we should use mechanical support. I don't have any disclosures. So the case is a 35-year-old female. She's a marathon runner who was brought to the emergency department by EMS after a syncopal event at home. She had had a right knee surgery 1 week prior to the presentation and really no other past medical history. As far as her medications, I didn't put that in, but the only medication she was on was oral contraceptive. The vital signs you can see up here: blood pressure 89/45, heart rate 125, respiratory rate 25, and hypoxic on room air. She's alert and oriented, drowsy but arousable, slightly pale appearing. She does have a significant contusion on her face from the fall related to her syncope. But she did not have loss of consciousness. She did have loss of consciousness. Her husband that was witnessed the event said that she came back quite quickly afterwards. She has JVP to the angle of the jaw. She's tachypnic, but cleared auscultation and no wheeze or crackles, tachycardic with regular rhythm, and a holosystolic murmur at the right sternal border. She has a brace on her right leg in the area of the surgery, mild erythema and swelling of the knee, and no lower extremity edema. So bedside echo was done in the emergency department, which showed an ejection fraction of 75%, a very hyperdynamic underfilled left ventricle, severe right ventricular dilation with severe dysfunction, and no note of right atrial or right ventricular opacity consistent with thrombus. So no thrombus in transition. And CTPE showed a large saddle pulmonary embolism, RV dilation with the ratio of RV to LV greater than 1, septum bowed towards the left, and reflexive contrast into the IVC. So this is a patient that we get called on by the PERT team, not infrequently, that she does meet criteria for massive PE, but she does have some risk factors for lytics given the facial contusion, the facial trauma. She did have a CT head done that didn't have any evidence of any hemorrhage. It was just more soft tissue injury. She is awake and alert. She is semi-stable, but with a very large PE and not a lot of reserve. And hemodynamically, her vital signs do meet criteria for the massive PE with systolic blood pressure less than 90 for at least 15 minutes. As far as the shock component is, do they have tissue hyperperfusion, hypoxia, altered mental status, oliguria, and cool, clammy extremities, all trying to evaluate what their perfusion is. For her, she was kind of borderline. She was definitely hypoxic. She was drowsy, but alert and oriented ×3. She labs were checked, but we didn't have them right away. And her extremities were warmish. She kind of continued to be on this borderline of what do we do? Do we just give her the TPA that was discussed earlier, half dose TPA? Do we give her full dose TPA? Do we try to get an urgent procedure done? Or do we start having discussions now about whether we have mechanical support for backup? Do we give her mechanical support now? So these are all kind of discussions that we have in a multidisciplinary team, kind of behind the scenes when PERT is called for these patients. And why this is important, we've kind of, as we've gone, we've slowly gone to more high risk pulmonary embolisms. But once, and this has been reviewed already a little bit, but once you have the RV dysfunction, the mortality does increase to 8%. But with the hypotension, the cardiogenic shock, and of course, cardiac arrest, the mortality increases exponentially. And then these are the type of people that we start talking about. They don't have a lot of reserve. If we're going for a percutaneous procedure with the goal of reperfusion, are they going to decompensate on the table? And should we be having these discussions up front to try to prevent that to happen? Or if it to happen, that we are ready and to provide the mechanical support needed. So again, as I've kind of alluded to, there's nothing clear, well, there's not a lot that's clear about these patients. They can look quite good when you're looking at them 1 minute and very bad the next minute. The treatment, as you've heard, there's complications with the systemic anticoagulation. We're getting much better with the percutaneous procedures. We're able to do them much more efficiently. The complications we've had are quite good, the rates are quite low. And we've had a lot of success. You would hate to wait for a procedure if the patient's getting is about to decompensate. So it's really trying to evaluate patients and get a feeling about how much reserve they have and be prepared if they decompensate. So the mechanical circulatory support strategy can be and has been hemodynamic support to allow for the anticoagulation and RV recovery. So essentially you put them on RV, the mechanical support we'll talk about, which is mostly VA ECMO. You give them, they're anticoagulated and you allow time for just that RV to recover. This is not really recommended, but is a possible option. You'd use a semi-elective cannulation prior to a planned procedure. Do you put them on VA ECMO up front, make sure that you have hemodynamic stability, and then go to try to approach the massive PE, or usually the large central obstructive PE. And then the other use of it is for eCPR. So after or during cardiac arrest. So VA ECMO is really our main go-to for patients that have massive PE, cardiogenic shock. And it really effectively unloads the right ventricle. I can't see it. So we've heard a lot about ECMO probably in the past, but essentially blood's pulled out of that RA and that IVC. So it's unloading that right ventricle, oxygenating it, and then back into the femoral artery. This can provide really full cardiac support and up to 5 liters per minute. There are a lot of complications to ECMO, so it's not something you just want to do without really discussion and ensuring that this is the right thing for that patient. In these patients, the most frequent complications are bleeding, which happens in 30%. Distal limb ischemia, because you have big cannulas in the legs, and a lot of these patients are very clamped down because of their cardiogenic shock or the requirement for vasopressors. Here's a picture of some of the different types of limb ischemia. And what we do to try to avoid the limb ischemia is, you can see this extra sheath here on the bottom right corner, which is a reperfusion cannula kind of pointed down towards the legs to try to ensure that there is adequate blood flow that's on the distal part of the legs to try to avoid that distal limb ischemia. The other thing that you hear about is north-south syndrome that is actually more common in these type of patients because of the normal left ventricular function. So on this picture here, you can imagine that you can see the blood that's coming up from the femoral artery coming up towards the heart. That's oxygenated blood that's coming from the ECMO circuit. And when the LV is very, very weak, that blood is able to really move all the way back to the LV, ensuring that you have oxygenated blood that is going to the right arm, to the head and neck, and all of the upper extremities. Patients with pulmonary embolism, though, they have a normal ejection or LV, and so they tend to have more deoxygenated blood that's coming out of the LV and having worsening oxygenated blood in the upper extremities and head. So that's why it's really important to be monitoring the pulse ox on the right hand. That's usually also where the ABGs are drawn in an A line, to make sure that we are providing adequate perfusion to the upper extremities, but most importantly to the brain and the head. One way to prevent north-south syndrome is central cannulation. And so this is a figure showing what central cannulation would look like. The benefits of it, there are larger cannulas and it avoids the north-south syndrome, but there's a lot of cons that go with that. And that is, this is an open heart surgical procedure. There's higher risk for bleeding, which also increased risk for infection, and reduced sternotomy needed for decannulation. This is a configuration that is sometimes, or what I've seen it more is if patients are already in the operating room and they decompensate and they have to come out on ECMO, sometimes they will leave them, or they will cannulate in this central configuration because it's easier to go on and off cardiopulmonary bypass. So again, ECMO really is our go-to for full oxygenation and hemodynamic support for patients with massive PE. There are a couple of RV supports that I will talk about, but I do want to say that really this is supporting the right ventricle. We can provide some oxygenation with this setup in particular, but there are multiple downsides to these devices that I'll talk about a little bit. So this is a combination of a double lumen pulmonary artery cannula. So you can see it's inserted through the IJ, and what it's doing is it's drawing blood from the right atrium. It's coming back to the external pump. You can also attach an oxygenator to that. And then through this dual lumen, it is putting the blood, oxygenated blood, back into the pulmonary artery. There's the couple different sizes of this dual lumen catheter, 29 and 31 French. So relatively large. You can provide a good amount of blood flow. And again, you can add an oxygenator to this pump setup. The other form of right ventricular support is this 24 French microaxial pump. So essentially, this is not an oxygenator. This is just for RV support. It's drawing, it's placed into the femoral vein. So you do not need the arterial access. And it goes up through the IVC, across the tricuspid valve, across the pulmonic valve, and into the pulmonary artery. The blood is the inlet is here in the IVC, and then the outlet is in the pulmonary artery. You can get a good amount of flow here, up to 4 liters per the manufacturer. So you can get a pretty good flow here. The issue with these non-ECMO devices are they really can support the right ventricle. The bleeding complications are lower because of the venous access. There are concerns about the fact that if you have a proximal pulmonary embolism or a clot in transit, you can be dislodging any of that clot and kind of pushing it further distal. They are typically used is if you have, you've already achieved reperfusion and you're trying to buy a little bit more time to allow the right ventricle to recover. That is where it's discussed most in the case reports. There are some small case reports that do talk about placing these devices at the time of, say, an ECOS catheter or ECOS to be able to provide the right ventricular support at the same time of ECOS. So really for this case, after this multidisciplinary discussion, the decision was the decision was to do this procedure in the cath lab with ECMO backup if needed, if she had worsening hemodynamics. At our institution, if we think we need ECMO, this decision has been to do these procedures again in the cath lab, just because they have more of the process down. They just do the peripheral ECMO placement much more often than interventional radiology. But fortunately for her, we made all these discussion and all these plans, and she did tolerate the percutaneous mechanical thrombectomy without needing the MCS. So any questions about these devices?
Thank you so much, Dr. Grafton. It looks like there's a question in the chat. Are there issues with ECMO venous drainage cannula being occluded by a clot in transit? Would a FlowTriever angiovac be used prior to ECMO in cases of clot in transit?
To be honest, a clot in transit is and cardiogenic shock is really a reason to probably go to the operating room, because then you will be on full cardiopulmonary bypass. But that is always the concern about you know, adding more percutaneous devices. The nice thing about ECMO is you can place it more distally. The cannulas do not go into the heart. And so you're not necessarily usually sucking the clot into the ECMO circuit. It might be possible, but I have not heard of that personally.
Yeah, and I think in the last PERT consortium meeting, a lot of the discussion had shifted towards many centers thinking about mechanical circulatory support as a way to just buy some time in these, you know, really sick massive PE patients to decide until a decision could be made about whether to go for surgery or to go for mechanical thrombectomy, et cetera. What are your thoughts on that approach as opposed to ECMO up front as a way to support kind of these procedures immediately?
Yeah, I think if you really think there's a high risk that ECMO is going to be needed, it's always better to do it prior to needing it for eCPR, because the mortality really is exponentially worse once a patient actually has cardiac arrest. So I do think that ECMO up front is probably better. And sometimes when we're trying to figure out what the best way to proceed. I think in our institution, it's somewhat hard because ECMO is somewhat of a bad word. And we're always held to such tight access to it. And so sometimes having these hard conversations about, well, she might not need it, she might need it, but let's do it, has always been somewhat difficult. And that's not, doesn't make it right, but is just a reality of what we do every day. There's some centers that have 20 patients on ECMO on any given day. And then that sometimes really does open up the ability to do it in a more proactive way.
Thank you. Are there any other questions for Dr. Grafton before we move on? Okay, awesome. Well, thank you so much.
Thank you.
All right. So next, I'll be talking to you about pulmonary embolism response teams. So we've really talked about the evolution of the various therapeutic interventions and modalities that are available for the management of PE. And that has led to kind of the development of these pulmonary embolism response teams to help in managing these complex patients. So the objectives of this session will be to talk about challenges in management of patients with massive and submassive PE, a team-based approach to PE management, and then our specific Henry Ford PERT experience. So the way that PERT started was really with this patient. She was 34 years old, lived in the Boston area in Massachusetts, was pregnant in the 3rd trimester, and suddenly became very short of breath, had chest pain, presented to a local community emergency room, and was diagnosed with PE. While she was in that emergency room, she quickly kind of started to decompensate from a respiratory and hemodynamic standpoint. She was transferred to a slightly larger hospital where she was delivered emergently via C-section. The baby survived kind of that initial, urgent delivery, but the hospital that she was at did not have the capability to deal with the massivity of her PE. And so she was then transferred to Mass General for further evaluation and management. And so by the time she got to Mass General, she was in cardiogenic shock, on multiple pressors and inotropes, intubated, on high ventilator support. And she ended up being placed on ECMO and had quite a protracted course on ECMO. So she was on ECMO for 6 weeks before she was able to be weaned off, and was discharged home after about 8 weeks in the hospital following this acute PE. And the physician team that was taking care of her there really, reflected on her case and thought through, how was it that this young woman who really suffered what should have been an unsurvivable event, what were the factors that resulted in her good outcome? And that was kind of how this idea of PERT teams was born. So one of the things that was recognized was that that they had the ability to bring together multiple stakeholders and subspecialists who all have different areas of expertise together to her bedside in a very timely, expeditious sort of way that resulted in this ultimately, though complicated, but ultimately good outcome for this patient. And so the idea of a team that would respond urgently to pulmonary embolism, similar to what we've seen happen in stroke and STEMI, really was born after the Mass General team took care of this patient. And so what they developed was a PERT team where patients would present with a PE There would be, obviously they have various robust fellowship programs. The PERT fellow would evaluate the patient, look at the history, physical labs, any testing that was available, and risk stratify the patient. You've heard us talk a lot about risk stratification today because it weighs so heavily on into the decisions that will be made in terms of candidacy for various treatments. And so the patient's risk stratified into low risk, submassive, or massive. If the patient has submassive or massive PE, then the multidisciplinary PERT team is activated, and they would have an electronic meeting where all of the different specialty stakeholders represented on the team would get together and have this multidisciplinary conference and conversation about what the best next steps would be for this patient or what the management plan would be. And they would make a recommendation to the primary team. And then importantly, on discharge, the patient would receive multidisciplinary follow-up in clinic. And so what had been happening to this up until then was that there really wasn't ownership of these patients, you know, in terms of who was going to follow them in what way, and there was no standardization to the either decision-making approach or for management or following these patients after discharge. And so from that, the PERT Consortium was born. So the PERT Consortium is a group of or an organization that is dedicated to the to promoting the adoption of the PERT model in healthcare institutions across the U.S. to ensure prompt diagnosis and treatment of PE, to expand the current body of scientific literature on diagnosis and treatment of PE through the funding of scientific endeavors, and to educate the general public and healthcare professionals regarding PE diagnosis, treatment, and care. And so we here at Henry Ford are also members of the PERT Consortium and are quite active with that organization. So I'll start with a case. It's actually funny because Dr. Schwartz actually showed you this case. He had different cuts of CT than I have, but there's some teaching points that we'll go through with this patient. So this was a 65-year-old male with a history of recently diagnosed small cell. He had recently been started on chemotherapy, received whole brain radiation, and had been on Decadron. He presented with weakness, poor appetite, emesis related to chemotherapy, dyspnea, and 2 episodes of syncope. Vital signs were remarkable for significant hypotension. Blood pressure was 72/54. He was tachycardic with a heart rate of 132 tachypnic, and was requiring 6 liters of oxygen to maintain saturation of 94%. And you can see he was on the hypothermic side as well. Labs were significant for acidosis. He had acute renal failure. And you can see his lactate here was elevated. BNP and troponin were also elevated. And he was leukopenic. Chest x-ray was done, which was unremarkable. And so he received 2 liters of fluid for the hypotension at an outside hospital ED, and then was transferred to our MICU. And in a patient like this, the differential diagnosis is broad, right? He's immunosuppressed. Sepsis is always on the differential. He could have been volume depleted secondary to emesis from chemotherapy. He had been on Decadron and now was in a stressful state, and so was adrenal insufficiency perhaps contributing to his clinical presentation? Could this be an MI or acute PE? And so a stat CT PE was ordered on arrival. And you can see clearly large saddle embolus, large clot burden bilaterally, and you can see his RV to LV ratio here is greater than 1. So there's clearly evidence of RV strain. And we had the luxury of having a prior echo in his case that had been done 1 month prior that showed normal RV and LV function. And so we talked about the RV death spiral and how increased afterload on the RV leads to this obstructive shock picture. And what's important to remember, you know, we've been harping a lot on the issue of the presence of RV dysfunction in patients with PE. We used to think of PE severity based on the extent of the clot burden or embolism size. And that has really shifted, where now we think of severity as a combination of embolism size, as well as what the patient's underlying cardiopulmonary status is or what their reserve is. And you can see that the mortality for patients with PE clearly goes up as the severity of the PE increases, and that mortality increases exponentially once you reach that shock state. Patients will very quickly progress to cardiac arrest and sudden death once they reach that shock state. The question is, can we find patients that are in this gray zone where we know that they have an increased mortality, but they don't yet have this clear indicator of shock and hypoperfusion that is clearly identifiable clinically? And so can we stratify patients by severity of RV dysfunction? And so we've talked a lot today about PE outcomes in massive versus submassive PE. And so obviously massive PE patients do worse. And we've made very little progress in that mortality over time. And interestingly, this was a study done looking at a large hospital database of over 10,000 patients over this decade here. And what they found was, and this was just looking at patients with massive PE who were hospitalized, and you'll see that the thrombolytic use, the rate of thrombolytic use has precipitously went down over that time period, despite us knowing that thrombolytics impact mortality in this patient population. And I suspect that it could be multifactorial. It could be due to kind of the feared complication of intracranial hemorrhage in these patients. It could also be a patient population that is older, sicker, with more comorbidities and perhaps contraindications to thrombolytics. But nevertheless, you'll see that the patients in this study who received thrombolytic therapy did much better in terms of survival or mortality, had lower mortality than those who did not receive thrombolytic therapy. So even though we know that thrombolytics reduce mortality, we probably aren't using as much of it or intervening as aggressively enough as we should on patients with massive PE. And so back to our patient, if we're to follow the kind of algorithm for risk stratification to try and determine what the next step would be, and something that I want to just quickly comment on here for all patients with acute PE, we often will get the PERT activation and people have not yet started anticoagulation because they're concerned that the patient may go on to need a procedure and they don't want to have the patient on heparin in case that ruins anything. And so I want to kind of debunk that right now and say, once you're diagnosed a PE, if there's no contraindication to anticoagulation, you should go ahead and initiate anticoagulation as soon as possible. We know that delayed anticoagulation or therapeutic anticoagulation also has impact on mortality in these patients. And any procedure we do, whether it's catheter-directed lytics, where obviously the patient is getting thrombolytic therapy, or even mechanical thrombectomy, which is done on a fully heparinized patient, the patient will be anticoagulated. So you will not be delaying or hurting the patient in any way by starting anticoagulation, and that needs to be done quickly. The second thing you assess is obviously hemodynamic instability. In the case of our patient, he was hemodynamically unstable. He's hypotensive with systolics in the 70s and has clear evidence of hypoperfusion as evidenced by his elevated lactate and his renal failure. And so the next step would be to proceed directly to reperfusion treatment and or hemodynamic support if needed. And so in our patient thus far, it should be very clear. He has massive PE, he should get systemic lytics. But he had a head CT done, which showed this intracranial mass. And then PERT was activated. So he underwent mechanical thrombectomy with the FlowTriever device. And this was the resulting clot that was removed. And so he had a very good outcome. His echo normalized after the procedure. And despite his small cell cancer, he went on to live about 18 months after this acute event. So our second case is a 69-year-old woman who presented to one of our sister hospitals with shortness of breath and lethargy. She had a past medical history of AFib, COPD, CAD, diabetes, and hypertension, and a history of cholecystectomy 2 months prior to presentation. Her vital signs were significant for kind of a low-ish blood pressure, but not quite meeting the criteria for systolic less than 90. She was tachycardic with a heart rate of 102 tachypnic and was requiring 3 liters of oxygen to maintain saturations. This is a representative cut of her CT. You can see she clearly has significant clot in her right and main PAs, and that extends out into the segments and subsegments. She had a troponin that was elevated at 2300 and an elevated pro-BNP. And then if you take a closer look here, she had this filling defect that was noted in the left atrium, which clearly should not be there. And that raised some concerns as to, you know, what that was exactly. And if you look at another cut of her heart, you can see this kind of serpiginous filling defect here, traversing from the right atrium to the left atrium. And so what you're seeing here is a clot in transit that actually traversed a PFO and was now sitting in her left atrium. And so PERT was activated here. And so let's talk a little bit about paradoxical embolization in acute PE. So it is rare, however, the incidence is likely underestimated due to underrecognition and underreporting. There was a series of 139 consecutive patients, and PFO was identified in consecutive patients with PE, and PFO was identified in 35% of them. And if you look at the mortality of patients who have PE, who have a PFO, it's around 33% versus 14%. So just the presence of a PFO, regardless of whether you see a clot in transit or not, confers a higher mortality risk. This really, I think, drives that home where you see the odds ratio for overall in-hospital mortality in the presence of a PFO is 11.35, so huge, with an odds ratio for a complicated in-hospital course of 5.21. And a complicated hospital course here meant stroke, arterial embolization, or the need for intubation. What about clot in transit, or right heart thrombi and acute PE? So the ICAPER registry gave us some sense of how common this was. So the incidence of right heart thrombi in that registry was around 4%. And you can see survival in patients who had right thrombi was much less than those who did not. And so also an independent mortality risk factor. Mortality due to right heart thrombi with heparin versus thrombolysis was 28.6 versus 11.3%. And this is consistent with other data. And so you may want to consider thrombolytic therapy even in the absence of shock in certain patients with right heart thrombi, given that we do have some data that suggests that thrombolytic therapy in that very particular subgroup of patients may be beneficial. But again, it's very small data sets and very hard to identify which of those patients will do just fine on heparin versus those that may require thrombolytic therapy. And so surgical pulmonary embolectomy can be a viable therapeutic option in patients with massive and submassive PE, particularly if there's a contraindication to thrombolytic therapy, if there's failed thrombolysis, whether systemic or catheter directed, or if there's shock that's likely to cause death before the thrombolytic can take effect. So remember, for systemic TPA, you still need about 2 hours. For catheter directed TPA, you're still talking about maybe 6 hours if you're using the optimized protocol, up to 12 hours if you're using kind of traditional TPA dosing. If a patient has recent craniotomy or spinal surgery, intracranial hemorrhage, recent major surgery, and can't get thrombolytic therapy, those would be times to consider surgical pulmonary embolectomy. But note that having CPR immediately prior to your pulmonary embolectomy confers a higher mortality. So surgery following CPR was associated with a 32% mortality versus an 8% mortality. And this is why our cardiac surgeons who are part of the PERT team really we involve them much earlier in the discussion than I think we ever thought previously that we needed to, because if we can get a patient to surgery before they've decompensated and deteriorated to that extent, there could be huge impacts on their survival. And so our patient underwent surgical embolectomy, and you'll see these are the clots that were removed. And this was a large clot that was removed from that PFO and that was traversing that PFO. Case 3 is a 62-year-old male with no significant past medical history who presents to the ED with shortness of breath and chest pain for 2 days. He had fairly normal vital signs on presentation and was just slightly tachycardic with a heart rate of 114. You can see on his CT scan, he had bilateral PEs involving his main pulmonary arteries, and he had extension all the way down to subsegmental level. He had RV to LV ratio greater than 1. You can see flattening of the interventricular septum here. You can see his RA is starting to enlarge as well. And he had an elevated BNP and troponin. On echo, you can see he has a dilated RV with a flattened interventricular septum. He has a hyperkinetic apex here with hypokinesis of the free wall, so consistent with McConnell's sign. And so if we think about this patient, so we've confirmed a diagnosis of PE. We should start him on anticoagulation. He is not hemodynamically unstable. So if someone's not hemodynamically unstable, then we need to figure out, are they low risk or are they intermediate risk? And the way we do that is we're going to check for clinical signs of PE severity or serious comorbidity and whether there's RV dysfunction or not. Using our risk stratification kind of calculators, the SPECI is what I use most commonly and what is part of our algorithm here. So if the SPECI is greater than or equal to 1, or the patient has RV dysfunction on echo or CTPA. So what we're doing is if the patient has both of these categories, or I'm sorry, either of these categories, then you'll do a troponin. If the troponin is positive, so that means they already have imaging evidence of RV dysfunction, and now they have biomarker evidence of RV dysfunction, then that patient falls into the intermediate high risk category. If we do the troponin and it's negative, then that means the patient still has some RV strain, so they still fall into that intermediate category, but they are lower risk because they don't have two categories of RV strain. So they only had imaging without biomarker evidence. If they have neither a high PESI score or evidence of RV dysfunction on imaging, then they fall into the low risk category. And those are not typically the patients that we're seeing in our ICUs, okay? If a patient falls into the intermediate high risk category, that patient should be monitored. And monitoring is used loosely here, meaning monitored bed, whether that's a tele step down, whether that's an ICU bed. We put them here in the ICU because we don't have a step down, but they should be monitored and consider rescue reperfusion if there's deterioration, which is in line kind of with that guideline update that we talked about earlier. All submassive and massive PEs should be hospitalized, and really that the early discharge or home treatment is only in kind of a select group of the low risk category, which again are not typically the patients that we're seeing in our clinical practice. We talked about the lytic trials that favor thrombolytic therapy when it comes to mortality and submassive PE. And so that our patient underwent catheter-directed lytics, and what you'll see is that his echo after 24 hours had started. You see his septum isn't as flat and is not as shifted over into the left ventricle the way that it was on the previous echo that I showed you. And then at 90 days, his RV looks much happier, much smaller. His RA looks smaller, and he certainly does not have any shifting of his interventricular septum here. So he had complete normalization of his echo. And then the last case we'll talk about is a 40-year-old female who presented to the ER with dyspnea for 10 days. Her vital signs were significant for a tachycardia with a heart rate of 132, a blood pressure of 133/76, tachypneic at 31. She was requiring 4 liters of oxygen to maintain saturations. She had a past medical history of unprovoked PE ×2 and had been on Coumadin, but she'd been off of her medications for 10 days. She was also morbidly obese with a BMI of 57. Now, interestingly, despite her being off of her Coumadin for 10 days, she still had an INR of 2. Looking at her CT scan, you can see she has clots in her bilateral pulmonary arteries. You can see some more here. And she has an RV to LV ratio clearly greater than 1, with her tiny little LV kind of very smushed on the side here, and significant dilation of her RV. She had a BNP of 185 and a troponin of 60. And so if we are to risk stratify our patient here, she does not have hemodynamic instability. Her SPECI is greater than 1. She had tachycardia. She was requiring oxygen, and so had at least 2 criteria there. And she had RV dysfunction on her CTPA. So she had both 1 and 2 present. She had an elevated troponin, and so she falls into the intermediate high risk category. And so this should be straightforward. She has a history of VTE. She was off of her Coumadin for 10 days. She probably just had another acute PE, and she falls in the high risk submassive category. So our choices are, we can systemically anticoagulate her with heparin, or we can offer her catheter directed thrombolytics. But is there something that we're missing? And is there something else that we need to look at differently in this patient? So we had the luxury in her case of having the prior imaging from 2016 when she had her initial PE event. And what you'll notice, this is 2016 imaging, this is 2018, you'll see that her clot distribution in 2018, so now, during this presentation, was very, very similar. You can see this clot almost looks identical to what this clot looks like in 2018, with similar RV dilation, except now it looks maybe a little bit worse than it did in 2016. And so in a patient like this, it's very concerning for CTEPH. And so she underwent a completely different path workup. And so, which I'm not going to go into because Reem is going to cover in detail kind of the workup for CTEPH, but she ended up referred for endarterectomy surgery and did not undergo any advanced therapies for this acute PE, because it really wasn't acute PE. This was just progression of CTEPH, and she just presented with worsening of her chronic disease. And so you can see the complexity of these patients. They're not all straightforward. There's nuances between patients or amongst patients, and there's a lot of heterogeneity within this patient population with, as Dr. Schwartz pointed out, lots of emerging modalities for treatment that we don't necessarily have randomized control trials to support, but they're out there and they're available. And so really, how do we handle this? And so about 10 years ago is when the first PERT was formed. And since then, there's been a movement kind of on a national scale to adopt PERT teams at these institutions or at our institutions. And there's data now to suggest that having a PERT team has an impact on survival in patients with acute PE, and looking at pre and post data, and that PE mortality is improved when a PERT team is present. I'd like to share a little bit of preliminary data from our experience. So this is a paper that was led by Dr. Koenig, looking at patients between 2013 and 2019. And this is under peer review right now. It's been submitted for publication. But you can see that patients who, we looked at patients who had catheter-directed thrombolytic therapy versus anticoagulation in submassive PE. Now, this was all comers of submassive PE. It was not focused on just the high-risk submassive PE, but you'll see there is a mortality benefit to catheter-directed thrombolytics. So 10.5 in the anticoagulation group versus 4.3 at 30 days. And that mortality benefit was sustained at 90 days and 1 year. And importantly, it did not come at the expense of increased intracranial hemorrhage or bleeding. And so really promising, encouraging data that I think is in line with what we're seeing kind of more nationally with some of the smaller series reported out of individual hospitals or small groups of hospitals when it comes to catheter-directed therapy. and I believe will be substantiated with the HiPytho trial, but we'll have to wait and see. So what about Henry Ford's PERT stats? So we launched in May of 2017. We provide 24-hour, 7-day-a-week, 365 coverage, decision support to all health system hospitals. We've had about 850 activations thus far. About 240 of those per year are for these high-risk groups, meaning submassive and massive PE, with an additional 40 to 50 activations per year that are in the lower risk category, making for about 300 activations per year. How do we stack up against historical controls as well as the PERT consortium? So when we look at our high risks, our 7-day mortality for high risk patients, we're at about 24%. That is compared to 50% for historical controls for massive PE. With the PERT consortium data a bit lower at 15%. Where I think we're right on par with 30-day mortality for high-risk patients with the PERT consortium, as well as 7-day mortality for the submassive PE group, which is very low. And then for the submassive PE group at 30 days, we are right on par with the PERT consortium, and certainly both are much less than historical controls. What about our length of stay? You know, there's always this concern that if we're doing these procedures, that patients stay in the ICU and they end up staying in the hospital longer. Our median length of stay is 5 days, both in the massive and submassive categories. And that is right where it really should be. So this data comes from a large study looking at over 10,000 patients in Pennsylvania hospital systems that were admitted for high risk and intermediate risk PE, and looked at their mortality as related to day of discharge. And so what you'll find is that early mortality is high. So these are the patients who you know, die in the ER or die very early on in their hospitalization from very massive PE. And you'll find that as length of stay increases, mortality again goes up, both in hospital and out of hospital. Both in hospital mortality goes up as length of stay increases. And there's this sweet spot that's kind of between 4 and 8 days, where both in hospital and out of hospital mortality are acceptably low, meaning, so out of hospital mortality here is important because it means we've discharged these patients and they've survived, they've done well, we haven't prematurely discharged them. And so for our length of stay to be at about 5 days is actually very good in this high risk patient population. This is our data looked at a little bit differently. So this is just the PERT database data. So it's a different cohort than the table I showed you earlier from Dr. Koenig's study. This is looking at patients that are in the PERT database from 2017 until now. And these are high risk submassive and massive patients. So there's no low intermediate risk in this group. And what you'll find is that our 30-day mortality between those who got anticoagulation only versus anticoagulation plus intervention, and intervention here meant catheter-directed thrombolytics or mechanical thrombectomy or TPA, the mortality is lower in those patients, and that mortality is sustained at 90 days as well. And again, importantly, that mortality benefit did not come at the expense of major bleeding, because there was no difference in major bleeding between the two groups. And so the PERT successes when it comes to clinical and patient care are that we've achieved inpatient length of stay comparable to or lower than national standards in this high-risk patient population. We've demonstrated an impressive mortality benefit in patients with intermediate high-risk PE. We've created a dedicated PERT clinic, resulting in improved outpatient follow-up with patients with PE and high-risk features, providing decision support regarding duration of anticoagulation for our primary care clinics and aiding in identification of CTEPH and post-PE syndrome. From a system and process standpoint, we've standardized the initial management approach to patients with PE and high-risk features, engaged key stakeholders to work collaboratively within a patient-centered care framework, and have widespread visibility within the health system as a source of support in managing these high-risk patients. There's improved relationships and communication between different specialty stakeholders through support in management and disposition decisions. And we've supported the launch of PERT teams in nearly all the health system hospitals as a first step to ensuring that patients can get the highest standard and quality of care wherever they present within the system. And as well as ongoing provision of subspecialty expertise and decision support to teams. And from a financial standpoint, have a positive contribution margin to the hospital over the past 3 years. From an education and research perspective, we've developed a robust institutional database, which includes all of our PERT patients, education, having these PERT symposiums to try and make sure that everyone is up to date on the latest developments in the PE space, and then research and recognition as a PERT consortium institution. And something that I'm really excited about is participation in these landmark clinical trials that are coming up that we're all hoping will give us a lot of the results and the data that we so desperately need in this space. And so a team that works well works synergistically together, and the combined power, I think, of all of the members of our groups when we're working together is much greater than any of us individually. And so we are very fortunate to have a very committed group of people on our PERT team who have really dedicated a lot of their time and efforts and energy into standardizing the care of these patients. And so in conclusion, PE management paradigms have changed little in the past 50 years, although I think that's shifting and evolving. Institutions are pioneering PERTs to streamline clinical decision-making for increasingly complex patients with PE. And clinical practice guidelines may lag clinical reality. We see that in all of our practice guidelines, that on the ground, there are different things happening and different technologies available, and they're coming around so quickly that sometimes there can be a delay in guideline recommendations. And so there's value in quickly bringing experts from several disciplines to guide management in helping improve patient outcomes. And again, this is our team. I'd like to thank every member of our team for their commitment and dedication to taking care of these patients. Thank you. And I'm happy to take questions. Okay, so with that, I will turn it over to Reem, who is going to be talking to us about follow-up of the massive and of the high-risk PE patient. So outpatient follow-up of the high-risk PE patient. I see a question in the chat though. Does the use of high-sensitivity troponins help identify high-risk patients that benefit from adjunct interventions to anticoagulation, explain better outcomes at Henry Ford compared to historical registry? You know, I don't know that it's the high sensitivity troponin per se. I do believe it's having the presence of a PERT team, because I think you will find that our outcomes are similar to the PERT Consortium's outcomes, which means that, and these are all, the PERT Consortium institutions are all institutions that have PERT teams. And so I can't help but wonder whether it's this multidisciplinary collaborative approach and early intervention on these, early identification, risk stratification, and intervention is why we're seeing these outcomes. So Reem is our nurse practitioner for the pulmonary hypertension program, and really has been instrumental in ensuring follow-up of patients in PERT clinics. So she helped found and create our PERT clinic here at Henry Ford main campus. Reem, you can take it away.
Thank you. So I'm going to be talking about the follow-up of the high-risk PE patient. This is a disclosure statement. The objectives of today's lecture is to define post-PE syndrome, review the pathophysiology of chronic thromboembolic disease, known as CTED, and chronic thromboembolic pulmonary hypertension, known as CTEPH, discuss the incidence and risk factors for CTEPH, review diagnosis and treatment of CTEPH, and discuss diagnostic algorithm for the post-PE syndrome. So we know that patients that are diagnosed with acute PE are at risk for recurrent VTE, as well as major bleeding from being on anticoagulation, as well as arterial cardiovascular diseases and CTEPH. But more recently, we've been noticing chronic functional limitation and decreased quality of life that has been recognized as long-term complications of the acute PE. And you can see in this diagram that these group of patients after PE will have reduced functional status and some with persistent thrombi. But really what defines post-PE syndrome is suboptimal cardiac function, suboptimal PA flow dynamics, abnormal gas exchange at rest or with exercise, exercise intolerance, diminished functional status, and reduced quality of life. The majority of all acute PEs will go on to have restoration and perfusion, but there are some factors that contribute to hindering this, and some of them including clinical factors, including the size of initial thrombus, RV strain at diagnosis, and delay in anticoagulation, impaired fibrinolysis, remodeling of the emboli, and any chronic inflammation states like osteomyelitis or infections. And these patients can go on to have persistent defects, which are associated with functional limitations falling under the category of CTED, with more severe cases that develop concomitant PAH falling under the category of CTEPH. So how do we diagnose CTEPH? It's really predicted on two specific findings. One being having hemodynamics consistent with pulmonary arterial hypertension, meaning the mean PAP has to be greater than or equal to 20, a wedge or LVEDP less than or equal to 15, in addition to PVR greater than 3 Wood units, along with perfusion defects despite 3 months of effective anticoagulation. And this perfusion defects has to be seen on either VQ scan with at least one segmental defect, CT scan or pulmonary angiogram, and like I mentioned earlier, after 3 months of effective anticoagulation. So we saw a lot of acute clot in a lot of the previous lectures, but this is really what CTEPH looks like in comparison. You can see that the clot starts to organize, it looks fibrotic in nature, and then once it starts to organize, it starts to attach to the medial layer of the pulmonary arteries, and it starts replacing the normal intima. Here, the groups of PH are broken down into two sides, one with defined treatments and one with not so clear treatments. Just noticing that Group 1 PH and Group 4 are the only ones where there's defined treatments. And the reason why we look for CTEPH so diligently is it's potentially the only curable form of PH. And it's classified as either inoperable or operable, with operable being surgically accessible disease and potentially being curable. Going over the CTEPH incidence, we're saying that it's a rare complication of a common problem. And if we're saying that it commonly precedes acute PE, how likely is it? This chart above represents epidemiological data that shows the incidence of CTEPH can range anywhere from less than 1% to 9%, with a more generally accepted incidence about 4 to 5%. So if we're diagnosing roughly 600,000 acute PEs a year, then we're saying that 24,000 of them would go on to develop CTEPH. And this is a very conservative number because it doesn't take into account the 20 to 30% of patients that are diagnosed with CTEPH that have no prior PE history. Looking at the CTEPH registry, you can see that about 75% of these patients had a confirmed previous acute PE, but really driving the point that 25% of them did not have any prior history of acute PE. So again, absence of PE does not rule out CTEPH. I also want to point out that 41% of these patients were noted to have massive PE in terms of their size, but only 14% of these patients received thrombolytic treatment, which really raises the question of whether perhaps inadequate initial treatment of these high-risk PEs predispose them to the development of CTEPH. So can we predict who will go on to develop CTEPH after their acute PE? I'm going to be going over a post-hoc patient level analysis of 3 observational studies. What was excluded is that the patients could not have terminal cancer or severe cardiopulmonary disease. They would go, it's studying 772 patients that would go on to have a 2D echo at 6 months. And if PH was present, they would go on to have chest imaging and a right heart cath. And they found that the CTEPH incidence in this case was about 2.8%. More interestingly, though, they were able to identify 4 variables that were used as risk factors that conferred the risk of development of CTEPH, and 2 variables that had a negative association with CTEPH. And they gave different scoring assigns to each of these variables. I just wanted to point out that if you had an unprovoked PE, you would get 6 points there, and any RV dysfunction on a CT or echo would give you 2 points. And the low variables were known DM and thrombolysis and having an embolectomy. I want to make note of the unprovoked PE and the RV dysfunction. So this is really the patient population that we're seeing here in our ICUs, So if a patient had a score of less than 6%, the negative predictive value for the CTEPH was nearly 100. And having a high score was associated with 10% incidence of CTEPH. So thinking about these risk factors can certainly help us improve our ability to better predict which of these patients would go on to develop CTEPH. But this is still a tool that needs further validation before we can use it widespread. As most of you know, the most challenging, one of the most biggest challenges of treating pulmonary hypertension is recognizing and then diagnosing it. You can see here the signs and symptoms of pulmonary hypertension are pretty vague and non-specific. I just want to mention that patients that have CTEPH, what's specific to them is that you can see hemoptysis due to bronchial collaterals that develop, and also bruise over the lung fields. This happens in 30% of patients, so it's low sensitivity but high specificity. And it's not found in idiopathic pulmonary arterial hypertension. So going over the diagnostic algorithm for CTEPH, if you have a patient that has unexplained dyspnea or high clinical suspicion for PH, or you see any kind of incidental radiographic findings such as enlarged PA or cardiomegaly, would start with an echocardiogram. If it's normal, you can consider a CPET to find other etiologies. If the RV is compromised in any way or you see pulmonary hypertension, you go on to order a VQ. And if it was normal, then you can rule out CTEPH as one of your causes and start looking for other PH causes. If there's any mismatch perfusion defects, it most likely indicates CTEPH. The reason VQ is the imaging test of choice is that it's 97% sensitive in comparison to a CTPA with only 51% sensitivity. And I just want to mention that there's more data that suggests that CTPA is improving, but the sensitivity will still remain lower than a VQ. So picking up our algorithm, if a patient has mismatched perfusion defects, you'd go on to order a CTPA. And this really will help us with 3 different things. 1, it can show us proximal CTEPH and we can use it as a surgical roadmap. Or you may end up needing more crowded information such as cardiac MR to help with right heart quantification of right heart function and flow mapping. A CTPA can also show you non-specific features of pulmonary hypertension without obvious findings for proximal CTEPH that would raise suspicion for more distal disease, in which case you would go on to order a PA to better identify segmental or subsegmental disease. Sometimes the CTPA can also show you alternative causes for VQ mismatch, including PA sarcoma, vasculitis, or fibrosing mediastinus, in which alternative diagnostic testing would be ordered next. I just want to mention a SPEC CT VQ. This technology combines CT and VQ to give us a clearer image for the diagnostic of CTEPH. And you can see here in the areas where there is a dark red would be defects. So this goes over a pulmonary angiogram, and you can see here, there's in the upper lobe and lower lobe, there's hyperperfusion and areas of even distal pruning. As I mentioned earlier before, CTEPH is classified as either being operable or inoperable. The treatment of choice for CTEPH is pulmonary endarterectomy. And operable disease, when there's surgically accessible thromboemboli, and in a patient who can undergo surgery with acceptable risk. Inoperable disease can be due to small vessel disease or unacceptable operative risk, or if there's hemodynamics that are out of proportion to the degree of obstruction that would require medical management. Going to shift gears to talk a little bit about CTED. We know that CTEPH, you can have functional limitations due to their underlying hemodynamics that are consistent with PAH. But what about those that have CTED, which is chronic clot associated with exercise limitation, but do not have PAH with hemodynamics? This was a really interesting study that compared exercise in patients with CTED and CTEPH to controls. And you'll see those with CTED had exercise limitations that were no different than those with CTEPH. For instance, CTEPH and CTED patients had decreased maximum work rate and end tidal CO2 and VO2 max that in comparison to controls. And you'll also notice that both CTEPH and CTED had higher dead space ventilation. And when compared to the controls, that's really the hallmark of pulmonary vascular disease. So you can see that even though these patients don't have hemodynamics that are suggestive of PAH, they really don't differ significantly than those with CTEPH with regards to their pathophysiology on exercise testing. Which raises the question, should we be doing more for these patients, because currently there are no approved treatments for CTED, but they clearly have the pathophysiology consistent with pulmonary vascular disease on exercise testing. So here we talked about patients with CTEPH or CTED, but what about these large group of patients that don't have either, but still have exercise intolerance? This is a study of 845 PE survivors who were anticoagulated and followed for at least 6 months. At 6 months, they had symptoms assessed with those with exercise intolerance compatible with post-PE syndrome, and they underwent an echocardiogram. 2/3 of the cohort ended up getting an echo, really showing us how common exercise intolerance is in the post-PE patient. And then I just want to point out that these patients were found to have diastolic LV dysfunction, about 50% of them, and another 27% that had intermediate probability of PH. Of those that had PH in the echo, the vast majority of them still had PH contributed to left heart disease. And then 25% of these patients had CTEPH or CTED. So the two important takeaway points is that the study tells us is that a large number of patients with post-PE syndrome will have left heart disease, namely diastolic dysfunction, as the etiology and screening for PH is very important because of the high prevalence of CTEPH and CTED in this subgroup. This is a proposed algorithm for workup for the post-PE syndrome. So if a patient comes to you and has persistent dyspnea for after 3 months following acute PE, you can consider ordering a transthoracic echo while working up other etiologies for dyspnea. If it's suggestive of pulmonary hypertension, you would get a BQ scan. If negative, go on to get a right heart cath that will either show you no PH, in which you'll evaluate other etiology of dyspnea, or PH, in which you'll go down the pulmonary vascular disease. If the BQ is positive, then you also would go down the pulmonary vascular disease and refer both these patients to a PH or CTEPH center, where they go on to either have a CTA, right heart cath, plus or minus pulmonary angiogram. For patients that have a low probability of PH on their echo with no other etiologies, this is a group of patients that that I discussed earlier about CTED, you would think, and you would still get a BQ scan. Because if it's positive, then you would think about exercising these patients to rule it out. And if they were suggestive of pulmonary vascular disease, then of course refer them to a PH and CTEPH center where they would have more workup. If the patient if the CPET shows other limitations, you go on to treat those other etiologies, or if it shows decondition or the VQ is negative, then you think post-PE related dyspnea, and you can refer these patients to pulmonary rehab. If the echo has low pH and you have another etiology of dyspnea, you would of course go on to treat the other etiologies. So the bottom line is post-PE syndrome has an impact on patients' functionality and quality of life. Again, CTEPH is the only cause of PAH, which is potentially curable with surgery. I just want to point out here that medical therapy should never delay referral to surgical evaluation. And just because a patient does not have a history of PE does not mean they can't have CTEPH, and this is why we still work them up in order of VQ. Workup for the post-PE syndrome or follow-up of acute PE. Make sure to get an echo, and if a positive VQ, referred to a CTEPH or PH center. Look for other causes of dyspnea. We just went over that diastolic dysfunction is one of the big culprits and as well as lung disease. More research needed on C10 and patient-reported outcomes and functional outcomes increasingly important to consider in PE trials. And that concludes my talk. Any questions?
That was so great, Reem. Thank you so much for that overview of post-PE syndrome. And we can open it up to the group now, whether they have questions about this talk or if there's any other questions before we wrap up for the day. It looks like there's a question in the chat. Assuming cost and scheduling isn't an issue, is there a scenario where SPECT CT or VQ is more useful than a VQ scan? I think with SPECT CT, you will be able to, you have the added advantage of having the CT, which will help delineate any parenchymal issues that might be there. And so will serve as that like anatomical roadmap, so to speak, with the CT. There are some patients that, for example, for various reasons, can't get a right heart cath or are so, very sick. And we need a kind of a quicker answer, then you can use CTVQ or SPECT CTVQ to help give you some of that anatomical information. And surgical centers are more and more adept and accustomed to looking at those sometimes in the absence of a pulmonary angiogram when you need to make a quick decision, for example, about referral to a surgical center. So yes, they can be helpful. Any other questions? Dr. Rivers is asking for the CME code for the conference. So Hashmi, I don't know why the CME codes didn't work like the normal ones that we use. If you could reach out to the group and let us know how to get CME credit for today's sessions, I'd appreciate it. Okay, it sounds like, yeah, it sounds like you're working with the group to arrange for CME credit. Okay, so yeah, just let us know how to, if there's anything we need to do to claim that. All right, well, thank you everyone for your attention. I know this was kind of a marathon afternoon session. I really want to thank all of our guest speakers for some excellent talks and a really great overview of pulmonary embolism management and the value of PERT teams. Everybody feel free to reach out if you ever have any questions. You know how to get a hold of us, and we're always happy to review any of these cases with you. It looks like somebody posted, I have a question, but didn't post the question, but I'm happy to hang around. Whoever's on iPhone and posted, I have a question, go ahead, let us know, either in the chat or feel free to unmute. For patients with HIT and PE that require anticoagulation, do we have a protocol for bival or argatroban? Yeah, we have protocols for both. And so there's order sets that you can order through Epic for both of those.
Thank you, Sarah, for arranging this.
Yeah, thank you so much. Thank you for speaking and taking the time to be here. So thank you, everyone. All right, well, I hope everyone has a great weekend. And with that, we'll adjourn.